Thanks a lot for coming today. I think maybe we'll get started. On behalf of the National Coalition for Cancer Survivorship and the American Enterprise Institute, I want to welcome you to AEI for this discussion about payment reform and the care of cancer patients. Last fall, the Institute of Medicine concluded that the cancer care system is, quote, in crisis, and proposed a series of reforms that are specific to the cancer care delivery payment system. At the same time, policymakers are considering broad reforms of the current fee-for-service payment systems. And so the question before us here today is this: how can we use the change underway in the broader payment and delivery system to address the issues raised by the Institute of Medicine, specifically as it relates to cancer, to improve the cancer care delivery system? And to discuss these things with us today, we have a wonderful group of speakers. Leading off, we're going to have a moderated discussion led by Dr. Tom Price, who represents Georgia's 6th Congressional District in Congress. He will be interviewed by Dr. Mark McClellan, the former Commissioner of the Food and Drug Administration and the Administrator of CMS, who helped craft and innovate many of the delivery reforms that are now becoming part of bipartisan healthcare reform legislation. We'll be followed by 2 panel discussions that we'll introduce later, and then we'll close the day with a talk by Dr. Josh Sharstein, the Maryland Secretary of Health. And so thank you for coming here today. Now please join me in welcoming Dr. Price and Dr. McClellan. I'll turn it over to you, Mark. Thanks a lot.
Thanks, Scott. It's a pleasure to be back here at AEI and a pleasure to be with all of you this morning. I want to thank Dr. Price for taking time out of very busy schedule and particularly challenging right now, and also all of you who are here this morning, both sponsors and participants in this very important event. We are here to talk about a lot of issues related to cancer care and physician payment reform, but I think it really all comes down to the steps that all of us can take to improve care. One of the main reasons that has been cited for the physician payment reform legislation that's moving forward in Congress right now is the rising costs in the Medicare program and how that led with the Balanced Budget Act and the SGR and the volume performance standards before that pressures on the payments that physicians receive for the services that they provide. And one main goal of this legislation is to get out of that vicious cycle of costs going up and payment rates getting squeezed down. But there's more going on than that, and I hope we can touch on that this morning too. Within physician payment itself, we're seeing a lot of movements outside of Medicare away from fee-for-service. It, in many ways, just doesn't seem very well suited to the direction that care is taking. I think actually care for cancer patients is really on the cutting edge of those kinds of trends in both care and the resulting trends in reimbursement. Fee-for-service just isn't very well suited to the kinds of personalized medicine treatments and supports that cancer patients can increasingly benefit from. What we're seeing in cancer care is a movement away from high volume treatments that aim to be provided at an increasingly low cost and towards combinations of treatments that are and services that are especially well suited to individual patients. That's very high value and very individualized, in some sense kind of low volume. Now, maybe we could take care of paying for all of these new kinds of services that seem to make such a difference for cancer patients, like efficient coordination of care, sharing of information on patients, use of very effective diagnostic testing to account for a patient's genomics and other characteristics that would influence their optimal treatment, telemedicine, other kinds of support outside of traditional doctor's office and hospital visits to keep a patient's care, to keep a patient's health as optimal as possible, the use of care teams, including nurses and social workers and other support services to improve a patient's quality of life, time to organize and then follow through on a very personalized treatment plan, ways of dealing with and actually heading off complications through new kinds of contacts with physicians, either in their offices or maybe through wireless technologies and smartphones. All of those kinds of things are what personalized care for cancer patients is all about, but none of them are paid for under traditional fee-for-service. And if we had maybe unlimited funds and fee-for-service could expand to cover everything, well, maybe that would be a good way to go, but that doesn't seem to be happening. And that's why I think outside of Medicare, we're seeing a lot of steps towards better support for these innovative and personalized approaches to care through giving providers, particularly under physician leadership, but clinical teams working together, and patients more flexibility in how care is delivered. We've seen in work that we do at Brookings, including with some of the people you'll be hearing from later this morning, new kinds of more person-focused models of payment to go along with these models of care delivery, things like oncology medical homes and partially bundled payments and other approaches that put more control and flexibility into the hands of the physicians, other clinicians, and the patients they're working with. But there's some challenges to these new kinds of approaches. One is a real concern that if you don't pay more for more services, you might get skimping on care. Now, fee-for-service has its versions of skimping too. Just ask any cancer patient who hasn't had the opportunity to sit down and talk carefully through a treatment plan at their doctor because their physician is rushed under the increasingly tight fee-for-service reimbursement rates, or a cancer patient who's back in the emergency room again because there wasn't financial support for a care team to help prevent those preventable admissions. But it does mean that there needs to be some attention to information on quality and cost and mechanisms for patients and their physicians to be able to choose the best care, to have some real autonomy in how they decide about services and deliver services under these new models. A second challenge is when it comes to developing personalized treatments, not just potentially valuable new drugs, but also reliable diagnostic tests to help target treatments effectively, and innovative approaches to delivering care that really do improve outcomes for patients. I know we'll talk some today about how not paying more for specific services could be a challenge to this. I think a lot of the supporters of these payment reforms believe that by giving clinicians and patients working with them more opportunities to change the way that they deliver care, that can get rid of some preventable costs like duplicative services or unnecessary admissions, and that reduced financial pressure would actually provide more support for better outcomes. But we need to take some steps to develop better evidence faster on which treatments work, including in actual practice, and take other steps to make sure that these reforms in care really do lead to innovation. These reforms in payments really do lead to innovations in care. So I'm sure we'll talk about all of those issues today as well. But right now, I'd like to start this dialogue with Dr. Price. And Dr. Price, I know you've been involved in both health care reform in Congress, but also real health care reform, helping doctors and patients in actual medical practice from your professional background for a really long time. And if you don't mind just starting out with some thoughts about the big picture in terms of where we are, and we can talk some about physician payment reform, the ACA, other big issues that are having an impact on cancer care.
Well, thanks, Mark, and thanks to AEI and all of you for joining us this morning. I know that most of you may have just wanted to get out of the cold, and it's nice and toasty in this room, and that's a good thing. I appreciate the opportunity to be with you this morning and share a few insights, I hope, and maybe a few pearls that I can pass on. But I think you nailed it. The things that we need to try to make certain exist in our healthcare system are flexibility for the patient and those providing the care, and innovation. There are a lot of things that we need to look at in terms of accessibility and affordability and all those things. But if we focus on flexibility of the system, to make certain that we can have a system and allow docs and others who are providing care the greatest amount of opportunity to care for that individual patient in the way that they deem to be most appropriate based upon the science of the day, then that's a good thing. One of my concerns in the innovative area is that we are possibly decreasing the level of innovation that we have in this country. I spent over 25 years taking care of patients, and some of my former colleagues now tell me that they no longer go to technical meetings in the United States because the technology that's being shown in the United States to docs is no longer on the cutting edge for many, many things. They're going to Europe and the Far East, and that ought to be of great concern to all of us. So flexibility and innovation, I think, are the key. And then finally, as an opening remark, I would just say what an exciting time we live in. What a remarkable time we live in, where the kind of science and technology that's going to be available and is currently available has the potential for changing lives in ways that we can't even dream about. Treatments, especially in the area of cancer, that could be personalized based upon one's genetic character. That's exciting stuff. We ought to be making certain that the system that we have allows for that kind of innovation and flexibility for that individual patient, as opposed to what Washington usually does, which is to have a very rigorous, straitjacketed approach to issues. And in the area of healthcare, that no longer can survive because knowledge and innovation is expanding at such a rapid rate. So I'm pleased to be here and look forward to the conversation.
Well, we're going to start this conversation between us, but we'd like to bring you all into it very soon as well. So I hope you all think of some questions, comments that you'd like to make to get this discussion going this morning. I'd like to start out just picking up on the points of flexibility and innovation. There's been a lot of attention lately to a couple of issues in healthcare, especially from a physician and clinical care standpoint. One is the ACA, and we'll come back to that. But I wanted to start with topic that's front and center here this morning, and that's the physician payment reform legislation in Medicare. Now, it does include some steps to fix the so-called SGR, this repeat vicious cycle of squeezing down payments every year. But it does some other things as well. It gives physicians an option of moving into some so-called alternative payment models that are intended to be, I think, more consistent with this goal of flexibility in care delivery and more opportunities for provider and patient control rather than just fitting into all the boxes of the existing fee-for-service payments. I'd appreciate your thoughts about the big picture on, is this legislation accomplishing the goals? Is it what you wanted it to be? It is pretty impressive to see this degree of bipartisanship and bicameralship, is that a word? In legislation, following on the work that you all started with Energy and Commerce and so forth. What are your thoughts about all of that?
Well, it is exciting to see because there's been a level of cooperation on this score that we haven't seen in a long, long time. The committees of jurisdiction, as most of you will know, are Energy and Commerce, Ways and Means in the House, Ways and Means upon the committee upon which I sit, and then Senate Finance. So 3 committees of jurisdiction. And amazingly, we've had virtual unanimity on those 3 committees on the goals to repeal the current SGR model, the sustainable growth rate model, the way that we pay and reimburse docs for caring for seniors, and attempting to move in a direction that has, as you say, some incentives in place for alternative payment models. Now, that's the good news. The questionable news, I think, is what will that bill allow? What will that law, if it comes to pass, allow under that alternative payment model structure? Will it allow the kind of flexibility and innovation that we've talked about, or will it be simply the wonderful folks here in Washington trying their best to make certain that they control the kind of apparatus that is available for patients? And I think that's an unknown. And that's why the information that you all can bring to us and the work that many of you do day in and day out is so important. Where's the bill going? I wish I could tell you. The cliff now is on April 1st, appropriately April Fool's Day. The current bridge expires on March 31st. I think that we will have a bill prior to March 31st, certainly through the House. I'm hopeful that we'll be able to get it through the Senate as well. We're looking at the challenge of the pay for us. It's always about the money. If you want to know where the challenge is, follow the money. The bill costs somewhere in the range of 140 to 150 billion dollars for a 10-year period of time. That's with the SGR repeal and the extenders that would be included. That's a lot of money, but it's around half or less than half of where it's been in the past. So it really is a deal at this point, and it's a fire sale, and it's time to buy. And so I'm hopeful that we're able to do so. When you look at the kinds of things that could be done, the Senate is insisting on not paying for it or using overseas contingency operations money, OCO money from Iraq and Afghanistan that's in the budget. The House is insisting on having a much more specific and I believe realistic pay-fors in the bill. That could be in the healthcare silo of the ACA. Or it could be in the healthcare silo of elsewhere, other entitlement programs and the like. So that's the challenge that we have. It's February 28th. 1 month is a short time, but it's also a long time in terms of the kinds of things that can get done, and I'm hopeful that we'll be able to do so.
Do you want to speculate any more, Dr. Price, or comment any more on where those pay-fors might come from?
I think I'll leave it at that for right now.
Yeah. I had a chance to talk with Dr. Burgess at an event that we did late last year, and he had a comment along the lines of, well, wait till the end of the parade to sort that out.
The problem is at the end of the parade, there are things on the street that are left by the previous passerby. So.
That's right. And as you said, we are getting pretty close to at least one end of the parade. Do you think the odds are pretty good for comprehensive action before April Fool's Day, or is this going to take a little bit more time to come together?
Well, I'm hopeful and mildly optimistic because we've never gotten this far. This is a huge event that has occurred over the past couple of months. Never have we gotten Republicans and Democrats in the House and the Senate to come together on the policy side. And I think many folks didn't think it would happen. Probably some of you in this room didn't think it would happen. And so I think it's a positive that we've come this far. Now, is the bill everything that I would want it to be, or any specific individual would want it to be? Probably not, and certainly not for me. However, when you have that kind of unanimity, it's important to embrace the opportunity, and there's a huge opportunity right now. I hate to think that we would allow the machinations of Congress and the concerns about specific items to cover the costs of this so obstruct the goal of moving to a system that is actually much more responsive potentially to patients that we would let this pass.
Right. And I'd like to talk a little bit more about these, as we said, alternative payment models that are a key feature of the bill for moving to more, as you said, more flexibility, more opportunities for innovation in the way that care is delivered and the way that treatments are used. But obviously there are a lot of questions about that, right? I mean, they're not very fully specified in the legislation. That's understandable because these models are in development, and if you want flexibility, you can't really specify in a whole lot of micro detail what exactly they would be. That's what created some of the challenges with the current fee-for-service payment system. But you said you had some concerns about where that might go.
Well, I do, and the concerns are because of past history of this administration and other administrations that tend to want to control things more than to allow the folks who actually are front and center in this, that is the physicians and the others providing the care, and specifically the patients. Patients and docs and others providing that care know best about what kind of treatment ought to be for an individual patient based upon science, not based upon whim or conjecture, but based upon science. And what we need to make certain is that the law and the regulations that are put in place to enact that law, if we're fortunate enough to be able to get it to that point, allow for that flexibility in the real world. And that remains to be seen. The good news that you alluded to before is that a lot of these things are now happening in the private arena right now, and it's important to appreciate that whether in the area of cancer care, This is an area that's exciting for patient-centered healthcare and team care and the like, the kinds of things that are moving forward rapidly in the private arena, but as you say, aren't being paid for in Medicare. So we ought to make certain that it moves in that direction. On the other side, I was an orthopedic surgeon, so there are things, if you have a fractured hip and you come in to have that hip taken care of, that's a pretty straightforward model. It's not. It doesn't require the complexity or necessarily the flexibility of a patient care model for cancer care. So if it's a one-size-fits-all that comes out of Washington for patient care for everybody, then I think that actually hampers the ability of physicians across the spectrum of medical care to be able to provide the highest quality care for their patients.
And we have seen a lot of good examples, and I think you'll hear about some of them this morning around the country that are changing the way that care is delivered to make it more personalized, to take advantage of some of the new innovations in targeted treatments and more patient-focused delivery of care that is possible today. Those we've seen, though, take a lot of physician leadership. This is not the default way of delivering care, and a lot of doctors are feeling under the gun today. One big reason is the SGR. A lot of them have concerns about liability if they do things differently. Speaking as a physician, one of the physician leaders in Congress, we talk a little bit about what it means to be a physician today and how important they are in leadership for these kinds of reforms.
Yeah, no, it's absolutely vital, I think, to have physician leadership in this, and I think that the law is flexible enough if it's interpreted in the right way to allow for that flexibility, the kind of specialty society work that is so necessary and imperative to make certain that the guys and the gals on the ground who are actually providing that care are able to have input into what the rules ultimately provide and the lanes in which they must run to take care of patients. But there are a lot of docs out there, and many of you know this, that have gotten incredibly frustrated with the current system, and understandably so. And many of them, I'm 59, many of my peers who are out there, especially in the surgical subspecialties, are throwing up their hands and saying, we're not certain we can continue to care for our patients in the way that Washington deems appropriate at this time. It's just too complex for us, and we're spending way too much time administratively and doing things that Washington thinks might help a patient, but in fact don't, and wasting all sorts of resources, and the margins have gotten significantly smaller. So there are a lot of docs who are out there who, unless they see some light at the end of the tunnel, I think are going to say thanks for the memories. I'm moving on, and that is a real that's a real danger. But it's also would be a huge loss for our country. Physicians historically over the last 50 years, between the ages of 55 and 70, have been really in the prime of their career. They have the experience that they've gained over the period of time practicing. They're the most efficient. They're usually the individuals who are providing that highest quality of care to their patients. And if we take those folks and say, you can't fit into this square, that you're a round peg, you can't fit into this round hole, go away, thinking that we're improving the system, that's a huge intellectual loss, capital loss for our country, and I think we ought to make certain that we ensure that they're able to continue.
Well, Dr. Price, we've been talking about how important Medicare reform is for physicians and patients in this country to get out of the vicious cycle with the SGR, and then, as you said, even if that law is passed, there will be some hard work ahead to make sure that these alternative payment models really do deliver on flexibility and innovation in care and saving money at the same time. There are reforms happening in other parts of the healthcare system too. A lot going on, as you know now, with the Affordable Care Act implementation. I wonder if you could comment a little bit on how you see that unfolding. Is it along the lines that you expected? Any surprises?
Well, I think it's along the lines that I expected, and maybe even worse than I expected. I wasn't very sanguine about the ACA moving forward, and I wasn't because I didn't think it embraced the kinds of things that we've talked about right here. the flexibility in the field to be able to provide the highest quality care for patients. I think it disincentivizes innovation, and I think that's a real challenge. And we're seeing a lot of things. The uncertainty that's out there right now in the healthcare arena is huge. One of the things and with the administration changing its rules from day to day or changing its interpretation of what the law says from day to day, doesn't work in the real world, as you know. And one of the things that's a real concern, I know, to folks providing cancer care because of its incredible upfront costs from a medication standpoint is the 90-day rule. And if you don't know as a provider whether or not a patient is really insured or not, and you go ahead and provide that care, and then you find out 2 months later, 3 months later that, joke's on you, by the way, we don't have any money to reimburse or pay you for that service, that's a real problem for docs out there, again, because the margins are so small. The narrower panels that we've seen headlines across the country, especially in the area of cancer care, of patients who have, you go through this, you set up a treatment regimen, you find a physician that you trust and believe is doing the best thing for you and the challenges that you have, and then lo and behold, you find out that panel has been where you're getting your coverage is narrower than one would have thought, and that person or that facility isn't eligible to you anymore. And then as we decrease reimbursements, as we ratchet down payment to those providing the care, and then of necessity, you decrease the money available for innovative procedures and innovative kinds of technologies. So I think we're sadly moving in the wrong direction, and I'm hopeful that to the extent that SGR, if it's reformed in a positive way, and as everybody in this room understands, it's not just about Medicare, about seniors, that the SGR is important, because virtually all payment models track off of the reimbursement levels in the sustainable growth rate for Medicare. So it affects everything else across the healthcare spectrum. So again, I remain cautiously optimistic, but I think that the administration has gone down the wrong road in so many ways with the ACA right now, that it's we're in a deeper valley than we were just a couple of years ago.
You know, I'm not saying anything new here in pointing out that the ACA is a very big political issue right now, and some have said that, yes, so some people have said that, well, look, fundamentally it's kind of similar to Medicare Part D and other approaches that Republicans have been for in the past, where there's a range of choices available, people get a subsidy towards buying the coverage that they want, and then the market takes care of giving people the kinds of coverage, the kinds of access to medical treatments they need. And Part D's been a pretty big success story. I mean, my own perspective on this, having been there to implement that, is that there are some big differences in the implementation. For example, one is that Part D got really off the ground, and to the point where just about everybody who was the intended audience for this program, all Medicare beneficiaries, including Medicare, Medicaid, dual eligible beneficiaries, including millions of people who qualified for extra subsidies, they were in the program by the end of the first open enrollment period, which is kind of March 2006. So this program looks like it's going to be going on and having a more prolonged and challenging implementation process than that. But I expect you see some differences as well.
Well, yeah, I would respectfully suggest that the kind of array of choices available to seniors in Part D bears little resemblance to the choices available to folks in the exchanges, especially because of the individual mandate and the employer mandate, and what it's mandating is what has to be included in the essential benefits package. So if we were to have used the Part D model, if Washington were to have used the Part D model, it would have said everybody needs to have health coverage, and here are your array of choices, instead of saying everybody needs to have health coverage and this is what you must buy. And the differences in the gold, silver, platinum, whatever the levels are in the amount of out-of-pocket expenses, what the premiums are, what the deductibles are. So the differences aren't choices for health coverage for individuals, that is making it more flexible and patient-centered. The differences are in what will your pocketbook bear. And that's the wrong focus. I think if we remember flexibility and innovation, if we concentrate on patients and we make it patient-centered and we provide the patients the greatest amount of flexibility to have select the kind of coverage care, the area that the docs that they want to have caring for them, the model that they want to be cared under, the greatest amount of flexibility. That's where we ought to be concentrating, and I don't believe that the ACA does that at all.
And just one more question on Part D. It's been back in the news recently because of some proposed changes in the program. There was a hearing in the House on this topic earlier this week. I don't know if you've been following that closely or have any thoughts about the future of the Part D program. It does have some bearing on drugs for cancer care. That was one of the original so-called protected classes that the drug plans had to cover.
Yeah, well, I mean, I think Part D really is a model that can be used, and I think it's been berated by some, but I think, and to your credit, when it was launched, and it was a huge challenge. I was here and remember how much work you did and everybody did.
Too,
yeah, in terms of education. But if you continue to ratchet down the payments for drugs, especially in the area of cancer care, then we will lose significant ability to be able to care for people in a vibrant and robust way, and in a way that again is patient-centered. It will be a boon to medical tourism. We're already seeing Americans who have the ability heading elsewhere outside the United States for care in many areas, and if we continue to ratchet down the innovation and the availability of cutting-edge medications, especially in technology, especially in the area of cancer care, then the medical tourism will expand significantly, and that's just not a good thing for the country.
Well, as you all can see, there's no shortage of important issues in healthcare policy and important issues that relate to the future of cancer care to discuss. At this point, I'd like to open the discussion up to some comments or questions from those of you who are here this morning. I'll try to find all of you. Just raise your hand and be sure to let us know who you are when you ask your question, and wait for the microphone. Thanks.
Hi, I'm Peter Ubel from Duke University. When you talk about promoting flexibility and innovation, probably one of the best ways to do that is to keep a lot of money pouring into the healthcare system. If there's more profit to be made, companies will have more incentive to innovate. Yet, I would expect you also would like to see a way to control costs of healthcare. So how are you setting the balance between promoting innovation and controlling healthcare costs?
Yeah, that's a great question. And the costs, you all will remember that this huge debate that's been going on for a long time, but also especially focused on the Affordable Care Act, or the Unaffordable Care Act from my perspective, and the focus on costs. There are a couple ways that you can hold down costs in any system, in healthcare especially. You can fix the prices, you can set the prices and say, okay, that's what we're going to pay, and you all figure out what you're going to do with that money. Or we can address the true cost drivers in healthcare. And I would respectfully suggest that we aren't addressing those at this point. What are the cost drivers in healthcare? You step back and take a look at the system, and they tend to be the same kinds of cost drivers that there are in any market when you have a market, plus one. And so the three main ones are taxation, the taxes that hospitals and docs and other providers pay get passed right on to the system. Regulation, we spend a huge amount of money in this country on regulation, and especially in the healthcare arena, the kind of administrative costs and costs for just the individual medical practice that has to comply with the kind of regulatory scheme that we have now and is expanding, adds inordinate amounts of wasted dollars, I would suggest, in many ways, to healthcare. And then litigation. The lawsuit abuse in this country is massive, and it's not the malpractice rates that docs and hospitals pay. That's not where the huge cost is. That's a significant cost, but that's not where the huge cost is. The main driver in driving costs up in healthcare from litigation is the practice of defensive medicine, which which is massive. And it's the kinds of things that doctors, every single physician does. I did, every single doctor does if they're honest with him or herself. And that is the things, the tests and the examinations and the things that you do to make certain that if you're ever called into a court of law, you can honestly look the judge and the jury in the eye and say, I don't know what you wanted me to do because I did everything. When in fact everything is rarely necessary to treat or diagnose a given patient. There's some studies out there that estimate, it's reliable studies that estimates it's between 1 out of every 4 or 1 out of every 3 healthcare dollars in this country wasted on the practice of defensive medicine. That's $800 billion. $800 billion, that's huge. So taxation, litigation, regulation are the three ones that many people talk about, and they're wonderful ways to solve those problems in positive ways that result in much more patient-centered care. The other area that I think drives up the cost is that we don't have any significant competition in healthcare. We don't have the kind of transparency of cost structure. We don't have the kind of accountability for cost structure. So when you don't have competition and you have the other 3 drags that on a market, then it's no surprise that the costs go up inordinately. And so I think if we stop trying to say this is what we want the cost to be in our healthcare system and fix the cost drivers of healthcare, we would save huge amounts of money, be able to provide coverage for everybody and make certain that it's done in a patient-centered way.
Now that's a pretty long and substantial list of cost drivers, but it sounds pretty daunting to fix as well. And I wanted to just come back a little bit more specifically to the physician payment legislation, which doesn't do anything, at least directly, about medical liability, might do something about the regulation of care. That gets to the point that you made earlier about how the actual alternative payment models will unfold, how much regulation versus how much flexibility in finding new ways to deliver care. But I did want to come back to Peter from some of your own work, some of the positive steps that might come out of the physician payment reform legislation, and that it basically moves some of the dollars that right now are channeled through these very specific fee-for-service approaches into resources that are given to the providers more at the patient level. So through potentially medical home payments or bundled payments or other approaches, maybe that's a way to get more flexibility in the system and maybe a way to get some better measures of quality of care at the patient level that physicians and patients can use to improve care.
Oh, without a doubt, as long as it is patient-oriented, patient-centered, and as long as it's the field of medicine, the field of healthcare, that is determining what measures are being utilized in that home to determine whether or not the quality is being arrived at. The problem that we have right now is whether it's through the electronic medical record, whether it's through PQRS, whether it's through the kinds of things that Washington thinks arrives at quality, in so many ways oftentimes has nothing to do with the quality of healthcare. Whether or not a given patient provides, whether you check a blood pressure on a given patient that you're seeing on a weekly basis for a fractured ankle who has no history of hypertension, you got to do that, and you got to make sure that you check that box, on and on and on. You know the kinds of things that are in there that take resources, time, administrative work, and the physician work away from caring for that patient in the most appropriate manner. So we get very specific oftentimes in this town about telling people in healthcare what they must do for that patient, when in fact the folks who know what must be done for that patient are in that clinic room, in that exam room, in that operating room. Sure.
Yeah. So I practiced in the VA system for 20 years. And I think
Why don't you use the mic?
Sorry. I'm a general internist. I practiced in the VA system for 20 years, and I think one of the advantages of that system was I had less flexibility because I couldn't know everything. And the system, there were people, and there were physicians involved in this, and sometimes groups of physicians decide better than an individual physician. But I think I had some constraints on what I could do, like, no, you can't go right to that medicine until you've tried this medicine for the patient because it works in most people and it's less expensive. And that, I think we can't just think doctors always know. Your own specialty. Recent study looked at what orthopedic surgeons thought different implants cost to put into people's bodies. They had no idea of the price, except that they underestimated the expensive ones and overestimated the price of the less expensive. So I think physicians have some knowledge about some things, but sometimes there's advantages to a system helping them constrain the choices a little bit.
Yeah, and I couldn't agree more. But don't misunderstand me, and maybe I'm not being clear. I don't think it's an individual patient, individual physician who ought to be determining the course of treatment for a given set of symptoms or a specific disease exclusively. But the folks that ought to be guiding what that individual physician does, and hopefully should be, are peers in that specialty. Folks who under the specialty societies, the folks who are looking at the array, who are in the academia arena, who are looking at the array of treatments available. It's just what docs have done forever. I'm a third-generation physician. The kinds of things that my father did for his patient, in spite of not having Washington tell him what to do, were the kinds of things that his specialty society and the work that was being done scientifically, medically at that time were deemed to be the most appropriate and effective for patients. The concern that I have is that so often in Washington here, what we do is we get solutions that are fixed in time. And the SGR is a classic example of that. And so we don't have the latitude, we don't have the flexibility in the system. And the VA has some wonderful aspects to its healthcare. It has some very, very challenging aspects to its healthcare, as you know. So there needs to be much greater, again, flexibility and innovation. If we keep the patient at the center and we have as tenets of a healthcare system flexibility for the patient, innovation for the patient, then I think we end up at the right spot.
Going along with the flexibility and innovation is also, at least in Part D and so forth, more accountability for the results, more accountability for and responsibility for keeping costs down on the part of physicians and the patients who are getting the care, more accountability for results that matter, and it's very hard in a fee-for-service system to get that. It's hard to even add up, as Steve Brill pointed out in Time Magazine. You've got thousands of different services, really hard to see how that all comes together in terms of overall quality of care at the person level as well as cost. Can you talk a little bit more about what you'd like to see going along with these reforms? So obviously not a whole bunch of detailed micromanagement of specific processes of care and measures related to that, but things that matter, maybe patients' experience with care, maybe measures that are more meaningful about overall costs.
Sure, and let me use it in the talk about it in the context of the defensive medicine practice that I discussed, because I think we can save hundreds of billions of dollars, but you got to change the culture of the practice of medicine, and so what we propose is to use specialty society guidelines. If a physician follows specialty society guidelines, which are guidelines determined by healthcare medical professionals about how to treat a patient in a given area. Not saying that they're confined by it, not algorithmic medicine, but these are the things that if you have a patient with this diagnosis, what you should do. If a physician does that, then he or she ought to be able to use that in a court of law as an affirmative defense. If the doc does basically the right thing, they ought to be able to have essentially a safe harbor. That doesn't keep anybody from going to court, but it makes it so that they don't have to, that you begin to change that culture of ordering that extra test when you know in your heart it's not necessary, providing that extra medication when you know in your heart it's not necessary. The classic one is writing a prescription for antibiotics when somebody has a sniffle. And it happens across this country, and it's not because doctors are trying to do the wrong thing. It's because they are so concerned, and appropriately so, with the litigious nature of our society. So if we relied on specialty societies for these guidelines and not necessarily on what some well-meaning intentioned folks in this town believe ought to be done, then that's all to the good. The reason that it gets out of kilter is that in this town we tend to look more at costs and pick some winners and losers as opposed to putting the patient at the center. A classic example is the disconnect that we have between paying for the same procedure in a hospital a different rate than in either an ambulatory surgery center or a clinic somewhere else for the same doggone thing. And we think that makes sense. What we're doing is driving patients at this point to the highest cost center in healthcare and not allowing for that flexibility and innovation. If we truly wanted a system that was patient-centered and patient-oriented and had that flexibility and innovation, then we would have site-neutral payments for care, understanding that it's important that you make sure that the quality of the care that's being provided is as high in one place as it is elsewhere, and you can do that.
Good comments. John?
Dr. Price, I'm John Sprandy. I'm a community-based medical oncologist in the Philadelphia area, practicing in a pretty diverse population, covering a pretty diverse population outside of Philadelphia. We've been promoting an oncology PCMH-like model in conjunction with the NCQA. We're involved in several initiatives. You touched briefly on something that that indirectly addresses or has something to do with physician payment reform, and that is rising out-of-pocket expenses. In our diverse population, we're starting to see more and more concern regarding the patient's responsibility from various plans that they've enrolled in. And that really ends up affecting physician reimbursement in a major way. And that's okay. It's up to us to manage that. But what we're really seeing now on the ground in the community is patients making decisions as consumers primarily and putting their medical needs a distant second. And it's been a little eye-opening, with the first of the year, when people have plans that might not be supportive for their cancer care than they could have chosen, and they're locked in at this point. We're seeing patients make decisions because of this economic pressure. It also, is another level of stress that patients really face in terms of rising out-of-pocket expenses when they're faced with a lot of other stresses as well. So in payment reform, I really appreciate all your comments, but in discussions about payment reform, is there some discussion about the reality of the rising out-of-pocket expenses, not just for our seniors, but also for the younger population?
Well, it's a tangential conversation that's being held because payment reform it focuses primarily on the senior population through SGR. But we have huge concerns. I have huge concerns about the increase in premiums and the increase in deductibles that most patients who are gaining their coverage through an exchange, either state or federally based, have no idea that either they're there or have no options to be able to select a coverage plan that allows them a lower level of premium or deductible. When the average individual goes from a deductible around $2,000, $1,500 for their family to a deductible of $6,000 to $12,000, that's massive. It might as well be $1 million. It doesn't make any difference. So this is a system, again, that is government-centered, not patient-centered. If we focus on the patient, and it may work for government, it may work for insurance companies, I don't know, but it certainly isn't working for the patient. And that's where I think we've lost so many times in this town our focus. We need to keep focused on the patient and make it so that, and I suspect many of those individuals actually had coverage before that was more workable for both the patient and for the physicians providing the care.
John, let me turn the question back to you a little bit. Some of the reforms that you're implementing really are about making cancer care more person-centered, more focused on the patient, and that can lead to reductions in overall costs. Fewer emergency room visits, fewer hospitalizations, more use of the most effective treatments recommended by the leaders in oncology practice. All of that can save money, but it sounds like you're saying that's not really translating yet into savings for patients.
What I'm saying is the rising out-of-pocket expenses are putting pressure on the two stakeholders that have the ability to implement significant change, meaningful change in terms of resource utilization and driving quality. It's the patients and the physicians. Rising out-of-pocket expenses puts a lot of pressure, additional pressure, on the providers and the patients. That stifles innovation. That stifles change at the practice level And let's not forget that 70% of our patients in the country today are receiving their cancer care from community-based oncologists still. Maybe it's 65%, but it's the majority. So what's happening with rising out-of-pocket expenses, I see it as the looming crisis in cancer care, quite frankly. And that's putting pressure on the two stakeholders that have the ability to make the change. I mean, government can't make those changes. Insurance industry can't make those changes. Policymakers can't make those necessary changes to drive those things. It's the patient and the physician that need to innovate. And you can't do that when you're under increasing financial pressure.
Stuck under these traditional payments. Well, I think that is a big challenge for the alternative payment models going forward. I saw some questions over here. John, do you want to? And then Joel.
Thanks. A very specific question. You've mentioned Part D and fee-for-service and all, but with cancer, you know, the injectable drugs are Part B, and I've read some articles. I think even Dr. Gottlieb might have suggested, I'm not sure he was prescriptive about it, but you know, that whole business model of the spread and all that stuff confuses issues, and having the spread subsidize the low fees. There's been some discussion from some parties of moving the injectable drugs into Part D. Is that something in discussion in your committee or with your colleagues at all?
No.
Comment from you on that?
Hey, you said it was a short answer. Said you were looking for a short answer.
That's right. Again, I think that the incentives need to be aligned so that the patient is, again, at the focus. So the patient has the greatest amount of opportunity to gain the highest quality care, whether it's whether it's in a treatment model, whether it's in a specific form of treatment, whether it's a surgical procedure, whether it's a medication, and oftentimes I think we've gotten off the mark on that.
And Scott, since John raised it, what the heck are you talking about?
Since that was invoked, let me clarify my my position. I'm concerned that as we move towards more bundled payment arrangements, which I think we are going to do under this SGR reform bill, because I think that's the easiest way for CMS to try to capitate payment rates, which is the trend. If we pay the provider and
notice what they said though. The easiest way for CMS. That we ought to be thinking about the easiest way for patients.
Well, unfortunately, I worked at the agency, so
Gotcha.
I have a sense of what I think is going to happen. You know, if the technology and the provider is paid under the same bundled payment rate, you pit the provider against the choice of technology in a way that could have an adverse impact on patients. I think we're seeing that in the renal bundle. We're seeing underutilization of important drugs, and we're starting to see health indicators that could be worrisome for the long-term health of the dialysis population. So we have a unique opportunity now to try to move the technology out of Part B into a competitively bid scheme. It doesn't need to be Part D, but some type of competitively bid scheme so you don't have CMS adjudicating utilization rules, payment rates around that technology, and they can bundle the provider and hold them accountable for some overall measure of efficiency, however they're going to end up measuring that, God help us, but not pay for the technology and the provider so directly.
No, I think it's. I mean, you know, it sounds wise. Coming from you, I'm not surprised. So, but that's the kind of. You know, maybe there ought to be an opportunity to have that be a voluntary selection by the patient and the provider, yeah. And be able to shift those resources so that you have the opportunity to gain the drugs. Because you're right. I mean, if you're paying a set amount for the treatment of a given diagnosis. And what the incentives are then, I mean, think about it. The incentives for the folks treating the patient are to utilize the least cost items in that care that they can, and still justify it intellectually and from a scientific standpoint. But that doesn't have the patient at the center. It has the payment at the center.
I think that's a great topic that I hope the panels later this morning will come back to. We've identified a lot of the problems with the fee-for-service payments in Medicare, and there is an opportunity to move to something else, but this is a good example of a very important issue that needs to be addressed to make sure that happens effectively. Joel?
Thank you. Joel Coopersmith from Georgetown. You started off by discussing innovation and how it's moving overseas, and doctors are going to meetings overseas to see the latest. A lot of the infrastructure for innovation has drifted overseas. partly because of the same reason as other things have drifted overseas. It's cheaper to do there. But what do you think could be done about that?
Well, I don't believe that companies move overseas because they necessarily want to. I think that the structure of our system right now oftentimes forces them to do so because they're making the wisest financial decision for their company. So when you have a country, the greatest country I believe ever in the history of the world, but it now has the highest corporate tax rate in the industrialized world, higher than anybody else, that in and of itself makes it so if you're doing a business plan, when you get to that line that says taxes and it says the United States, it says go somewhere else, because it's not appropriate to be here for you from a business standpoint. So there's so many ways that we can incentivize the ability of businesses to be created and expand right here. Taxation and regulation are the two biggest impediments to business being able to either stay here or to expand here. I visited Edwards Life Sciences out in California a year or so ago, and was stunned, and then learned so many other things that caused me to be more stunned than this, but stunned to learn that the technology it has existed for a number of years for the ability to to transcutaneously place an aortic valve, replace an aortic valve. The science was there, the technology was there, and the United States had 46 nations that approved that. 46 countries on the face of this earth approved that technology for patients, life-saving technology for patients, before the United States did, because of regulatory scheme that we have. And if we were to streamline the ability of the regulatory process to make it so that it doesn't take 5, 6, 7 years, technology is moving so rapidly, it doesn't take 5, 6, 7 years to approve a single procedure and then get in line to see if you can get the next cutting edge technology. So the regulatory mechanisms that we have in place right now, I believe, are harming the ability of the American people to gain the highest quality care.
We have time for maybe one more question. Go ahead.
Hi, I'm Shelley Fold-Nasso with National Coalition for Cancer Survivorship. So, Dr. McClellan, you asked Dr. Price his views on the Part D proposed changes and the controversy, but I think we'd be interested in hearing your perspective on it.
Well, I was told this event was about my interviewing Dr. Price, not about.
I'm interested in this too.
Yeah, I think a lot of issues came up at that hearing this week, and I think this is not obviously not a settled issue. When several hundred groups, from ranging from patient advocacy groups to health plans to pharmacy groups to drug manufacturers, can all get together and say, look, we need to re-examine this set of proposals. I think that's a good reason to step back and re-examine the proposals. Part D has worked well, I think, in good measure, because there has been this balance between flexibility that Dr. Price was highlighting, finding better ways to design benefits, finding better ways to get the right drugs, and in many cases the most cost-effective drugs to patients, but at the same time having some standards in place like the 6 protected classes, like the actuarial equivalent standards, was really about striking that balance. So if you're going to do anything to shift that balance for a program that seems to be working pretty well, you need to do it really carefully. And I think there are going to be a lot of comments on this proposal forthcoming. I've been working with a number of groups that have had concerns and thinking about how to best have them addressed going forward. And I think and hope this will be a process that CMS will look at very carefully before making any making any definitive changes in the program. The satisfaction rates are really high. The access to needed drugs looks very good. Definitely the program can always keep being improved, but got to be careful for a program that's working pretty well about making any big changes. But I don't think I should be the one answering the last question in this. Dr. Price, any final thoughts before we wrap up about big concerns or opportunities you see, particularly related to cancer care?
Yeah, let me just thank everybody for the work that you're doing to try to put the patient first. The reform bill that we put in place or introduced for now 3 Congresses in a row is entitled "Empowering Patients First," because I get so frustrated as a former practicing physician that we don't oftentimes start and end with the patient. We talk about all sorts of other things, but the patient needs to be kept at the center. And then just remind folks that this is a dynamic process. It goes on and on and on and on. It will never end, and it shouldn't. We always want to be striving for the best. And we go through fits and starts, and sometimes we're at a peak, and sometimes we're at a valley, and don't get discouraged. Continue to battle. It's important to continue to battle on behalf of patients, because those patients are you and me and our families and everybody that we love and care about, and it's so important, especially in the area of healthcare. It's an incredible privilege for me to be at front and center at a time when there's so much opportunity to improve our healthcare system in a very, very positive way. If we can ever help in any way, we're at tom.house.gov, tom.house.gov, and I look forward to continuing this work for years to come. Thanks so much.
Dr. Price, privilege working with you always. Thank you. Thank you.
Thanks.
Perfect. We're going to transition. We're going to transition right to the first panel. I think. Where's John? He's in discussion. Mark did a nice job. It's too bad he's leaving. Leaving now? Oh, he's actually playing. I'm lucky I got him. Twisted his arm. He did a great job. Where is John? He went to the bathroom? Kelly, do you know where John is? Probably where he won't be able to go. Good one chance to do that next however many years. You know, I spoke to everyone once at one of their events. I couldn't get a question. Generally good. I mean, he's got, like everyone else, he's got his points. He's good when he goes off the road. Some people aren't. So how many docs are there now in Congress? Like 20. I don't know. There's got to be that. Yeah, mostly Republicans, too. Yeah. Interesting. And in the Senate, just COVID? Well, no, there's Barassa, there's I don't know. So we're going to roll right into the first panel. I just want to, I'm going to actually let the, I'm going to give a very brief introduction to the panelists and then let them introduce themselves. Michael Oncology is the National Medical Director of Oncology Solutions in the Office of Chief Medical Officer at Aetna. John Sprande is the chief of medical oncology and hematology at Delaware County Memorial Hospital and director of the Delaware County Regional Cancer Center, and a member of the Fox Chase Cancer Network. And Peter Ubel is a professor of medicine at Duke University and the author of a book, Critical Decisions: How You and Your Doctor Can Make the Right Medical Choices Together. You've probably seen his stuff in the New York Times. He's a regular contributor, and he's an all-around iconoclastic thought leader. And you saw some of his mixing it up here today, so this panel should be pretty good. I'm going to let the panelists open up with 5 minutes of their thoughts, and then open up to questions from me and from the audience, and let them give a more appropriate introduction of themselves than I just did. Thanks a lot. Go ahead.
Thank you. Thank you, Scott. I'm Mike Collode. Many of you know me. I was a practicing oncologist for over 20 years, initially in academic medicine and then subsequently in community practice, where I practiced in Albany, New York for 16 years. And during that time, I was also part of the physician leadership of U.S. Oncology and medical director of U.S. Oncology. I joined Aetna 1 year ago. We can talk about why I went from the provider side to the payer side. I'm very interested in oncology. It's the only thing I know anything about. So anything I say today has only got to do with oncology. I'll say initially that I'm apolitical. I'm happy to offend both sides of the aisle equally. And I'm not iconoclastic, but I have a few opinions. And you know, when you first start working for the health plan, they say, well, when you speak, you got to make sure that you tell them when it's your opinion versus the health plan's opinion. So to be safe, everything I'm going to say today is my opinion. I do have some influence on what we do, but it's all my opinion. So when the Institute of Medicine put out their report last fall, I think they really wanted it to make a splash, right? Crisis. So it lasted about 24 hours in the news cycle, give or take, which is too bad. You got to ask yourself, why did it only last 24 hours in the news cycle? And I'll give you 3 possible explanations. One is, we think we're doing pretty good. We think we're doing pretty good because breast cancer survival continues to improve. We think we're doing pretty good because if you compare us to how things are going in Europe, we're doing pretty good. People think we're doing pretty good. Second of all, patients love their oncologists. If you look at patient satisfaction surveys, they always like their oncologists. They always get high scores. So they like their doctors. They like their individual relationship with their physician. And the third thing is, we treat cancer by press release, right? Or commercial, or headline. And damn, we are winning that war. The only truth is that we're not. And we're not, and we're spending a lot of money not. So the things that were written in that Institute of Medicine report, if you ask John or John Cox, people in practice, those things resonated with people who practice oncology and think about how oncology is practiced. Let me give you a couple anecdotes from my personal experience. You would not believe how often you sit in the office and the patient comes in and they tell you they saw their cardiologist who ordered a CAT scan and changed their medicines. You had no idea. Or how often, and I am embarrassed to say this, you started a patient on chemotherapy and you sort of knew they had diabetes, but you gave them steroids and all of a sudden their blood sugar is through the roof. You didn't call the endocrinologist. So is there a crisis? There is, but these are a lot of near misses. My point is this. If we think that healthcare reform, the ACA, SGR, is what's prompting reform in oncology, you're wrong. Reform in oncology has to happen because the way it's being done now, and again, I know nothing about anything else except oncology, is just not good enough. It's got to be better. So why did I go from the provider side to the payer side? Because I thought I could do better. I thought I could be more impactful. I'm not sure that's true, but that's why I moved. So at Aetna, and as a representative of Aetna and as a representative of the commercial insurance side, we are working very hard at all the kind of stuff that the congressman talked about, alternative delivery models. We have a pilot with John. I'm bullish on the patient-centered medical home. I'm very, very bullish on continuous quality improvement as a component of cancer care delivery. But it ain't gonna be easy. This is a complicated problem. Remember that most cancer care is delivered in the community, and most community oncologists they're little guys. They're 4-doctor practices in Fargo. And they got a long way to go before they're ready. And I'm really, really concerned that although we give lip service to the patient's perspective, I don't think patients know very well what we're doing. In fact, I'm quite sure of it. I sometimes tell the joke that let's go on the street and ask how many people know what it means to be attributable. Would you like to be attributable? Well, I assure you, you will be attributable if healthcare reform goes the way that they say it's going to go. That is either good or really, really bad. So I look forward to the discussion today because I think there's a lot of opportunity. I am, in fact, optimistic that we can get there. I'm not sure the government's going to do it, but I think we can get there if we put our mind to it, and that actually it'll be better for everybody.
I've never been described as an iconoclast before. I'm so excited to look for an iconic in class now. I want to start off with I'm going to mainly tell you a couple stories. Chris Tribble is a gentleman who lives in North Carolina, 75-hour-a-week working in the trucking industry, who had blood in his stool, went to a local doctor, and then eventually a local oncologist. He was diagnosed with colorectal cancer. He eventually ended up at Duke University for his care. He saw a friend of mine, a physician, a GI oncologist, Yusuf Zafar. And he was given oral chemotherapy to shrink the tumor. I think I have these details right. I'm not an oncologist. Prior to surgery. So he goes through chemo, responded well, the tumor shrunk, didn't have many side effects, had the surgery, really unfortunate. At surgery, they realized he had liver metastases that hadn't shown up in the imaging. I guess surgeons can sometimes see things that scans can't. So he came back to his oncologist, my friend Yusuf Zafar, who actually told him this news about the metastases, and actually he, the oncologist, cried. I have so much respect for oncologists, for nurse oncologists, people working in that field, because you face so often such tragic things. 39-year-old guy with metastatic disease. Cries with him about it, and then says, I really think we need to go back on chemo. And then Chris Tribble said, I can't. I can't do that. Why? I mean, you didn't have side effects, it shrunk the tumor. He said, it cost me $300 every 5 days. Do the math, that's almost $2,000 a month. The average person in retirement age in the United States has $30,000 of savings. So this had shot through his bank account, and he could not afford the chemo anymore. I should tell you about my colleague Yusuf Zafar. He has spent the last few years, not only when he's not seeing patients with cancer, he studies the financial distress caused by cancer treatment. He had just given this man this $60 a day chemo, and never asked him about what his out-of-pocket costs were. And then that gentleman, and knowing, once this guy said to him, I can't afford it, he was just like, oh my gosh, I could have given you IV therapy that would have been just as effective against the tumor, and it would be paid for by insurance from all the weird reasons we just talked about. But I just assumed you wouldn't want IV therapy. For medical markets to work well, I mean, I think we're moving towards people having more out-of-pocket costs, more skin in the game, don't like the term, but that's what's used. And I think that preceded the Affordable Care Act. Consumer-directed health plans were getting more common. So people had higher deductibles, higher out-of-pocket costs. We're moving hopefully towards price transparency, but what I want to just talk about is how ultimately, even with those things in place, with finances at stake for patients, and with prices out there, there's still a lot that goes on in the doctor-patient relationship that determines decisions. I'll give you another example. I finished a study recently with Angie Fagerland at the University of Michigan, of men with localized prostate cancer being cared for in the VA system, men who can choose between treating the cancer aggressively with surgery or radiation, or can watch it because it's such a slow-growing, localized tumor. The people who get the treatment, more active treatment don't have to worry about coming in every 6 months and wondering whether the cancer grew out of control. But they probably have to face having impotence and or incontinence. Classic example of a decision where the right choice depends on the patient's preferences. We found that patients, before they went to see their urologist, and we'd educated them like any good market would about these choices, some were leaning towards surgery, some were leaning towards away from surgery, and that did not at all predict what treatment they got. Some were sexually active and wanted to remain sexually active. That did not influence what treatment they got. Instead, we pushed a tape recorder in while they met with the urologist, and what determined their treatment choice was what the urologist recommended. And when the urologist's recommendation was based almost exclusively on how old they were and whether they had fancy terms, either Gleason 6 or Gleason 7 tumor, means really early or just less than really early. And they just basically said to the young men who had these Gleason 7s, you have to have this taken out. And to the older guys, you should stay away from any active treatment. It took a very rare patient. One guy, for example, a young guy said, look, I just have a new girlfriend. I'd kind of like to continue to be able to have sex with her. Could we at least hold off on surgery for a couple years? Because after a couple years, we all stop having sex with our partners, right? This is what I'm told. It's not from personal experience, of course. Anyway, yeah, I'm losing the audience. Sorry. Physician recommendation, the dominant predictor of choice. For markets to work well, you have to remember, consumer markets, it's very different than medical markets. In medical markets, there's so many more decision makers, insurance companies, hospitals, doctors, and patients. And because it's so much more complicated, that's a huge challenge. So I'll leave it at that, and we can revisit this.
Let me ask you a quick question. How much of the problems that you see with the issues around the cost sharing in the story that you related, it relates to the fact that, you know, insurance isn't doing in healthcare what traditional insurance is meant to do in other settings, which is insure against catastrophic risk. We have an insurance scheme in healthcare that leaves us underinsured in many cases for the catastrophic risk and overinsured for the routine things. So your vaccines are free, even though we know we're going to have to get vaccines every year, but you have a 30% copay on your cancer drugs.
Yeah, I mean, we often forget the distinction between insurance and insulation, right? Right? I mean, that if you know it's a predictable expense, that's why are you insuring for it? I know I have to replace my roof every however many years, my shingles, but I don't have home insurance that pays for that. It's right, but in healthcare we do. The fact is, though, a lot of these consumer-directed health plans do ultimately cover for catastrophic costs, but you spend a lot of the money till you get to that point. And given how little many Americans have saved, it doesn't take much before that cost to you is catastrophic. And then the second quick response I'd say is, when people with so much at stake, if they're not made aware of their alternatives, then they can't make that informed choice and decide how much is it worth for me to spend on this.
Thank you for inviting me here today, and I'm really happy to be here. I wanted to echo a couple comments in the next 5 minutes that Dr. Price made and also that Mike made and referenced the IOM report. I really do believe that cancer care is in crisis. And I think it's fairly late in the game. There is, I believe, some hope for optimism through payment reform and primarily through payment reform. It's not just the overly optimistic view of a practicing medical oncologist, which we need to carry a healthy dose of this to work with every day. But I really do think that it can happen. One of the things that we've done, and many of you have heard me speak before, is that we really are promoting a model of cancer care that really does promote process standardization. Oncology is very rich in secondary drivers of care, and we're very rich in guidelines, the NCCN guidelines, for example, the Commission on Cancer, multidisciplinary guidelines, and so on. We're very rich in treatment standards. One of the secondary drivers, which I think is very, very important for future payment reform models, whether it's a bundled model or a PCMH model, is process standardization. And so we're promoting a model that really infuses the PCMH process standards as a secondary driver. These secondary drivers impinge on the primary driver, which really hasn't gotten a lot of attention. The primary driver really is the physician-led care team. And we do need, I think there's a lot of variability in how patients are cared for, the process of care, the workflow, their recognized responsibilities as reporters, their understanding of the fact that when you're under treatment, we're the point of first triage, all those things. So the execution of care by the primary driver, which is the physician-led care team, is something that we've really worked on a lot. And it's because of really of the using the PCMH standards as a secondary driver. PCMH standards are things that everyone in this room would want if you were a patient being treated for any condition at all. So we've gotten a lot of attention by focusing on how care is executed because we can drive desired outcomes in oncology. And the desired outcomes in oncology are pretty self-evident. I'm not going to list them, but it's the right treatment, the right care, staying healthy, keeping out of the hospital, and so on. Rational care at the end of life, and consistent survivorship care. So we've attracted a lot of attention along those lines. When you talk about payment reform, I can tell you some payment reform stories locally. At this point in time, I'm happy to report that 54% of our patient population is now being covered by an alternative payment methodology with 3 dominant payers in our region. And so the non-government payers, actually one of the payers is a Medicaid HMO that we've had a contract with for 3.5 years, shortly after we were recognized by the NCQA. So it's happening, and that's what's really driving my hope and optimism. We have a company, Oncology Management Services, that's working with NCQA on a PCORI-funded effort in southeastern Pennsylvania to transform practices along the lines of this model. And I'm participating in some other national efforts with the technical expert panel and also a bundled payment consortium that Zeke Emanuel is leading up. So one of the things that I try to infuse in those discussions is the importance of standardization of process. Budget payment systems, I know, are the end game for a lot of strategists, but you need process standardization in place to really act as a patient safety net, I do believe, based on our experience. The other thing that was mentioned, and I think should be continued to talk about, it's the rising out-of-pocket expenses. It's becoming more of an issue. Cancer patients, I think, in general, are being approached the same way that a 35-year-old athlete is approached who has back strain from some weekend activity and is demanding an MRI. It's okay to be consumer conscious and understand how much you're spending, but when you're in a position where you don't really have a choice, patients are now making decisions not to be treated. It happened twice in my practice with my patients alone in the month of January, and I can't tell you how distressing it is because it represents a failure on my part to not perhaps educate the patient enough, but I know that I did. They made a conscious decision. So that's a major issue. It has other ramifications too. It does impact payment to physicians, and what happens is if you talk to oncologists, community-based oncologists, there's rising bad debt that we'll never collect, and that's just a fact of life. But that really does stifle innovation and investment at a time when it's really needed most. The financial or the economics of realities of that drive more practices to a higher cost setting, which in turn increase out-of-pocket patient expenses further. So that's the big crisis that I see, but I'm hopeful that payment reform in whatever methodology is eventually endorsed. It's going to be a few methodologies, I would suspect, but now's the time to do it and to do it quickly with some direction in terms of paying attention to process and making a standardized process part of those secondary drivers in order to make sure that patients are cared for properly.
Thank you. I want to ask a few of my own questions to the panel and then turn to the audience. Michael, you're in a position now where you both interpret rules for doctors and make rules that doctors have to comply with. I look at the SGR bill, and it seems to me hopelessly complex. And this is just the statute. We know it's only going to get an order of magnitude more complex once they try to interpret it in regulations. My belief is that an independent provider group, even one of scale, is not going to be able to interpret this bill and comply with all its dictates and try to navigate around the different payment mechanisms. And I think you can't, in this environment, opt not to take Medicare, but you perhaps, especially if you're a primary care provider, opt only to take Medicare patients under the auspices of a Medicare Advantage plan, where you deal with Aetna's rules, which frankly are going to be more interpretable, I think, than CMS's rules. And so I actually think this could drive more primary care physicians into the Medicare Advantage program, where they're going to see Medicare patients. It leads me to my question to you, which is, what do you see with respect to this complexity, particularly as it relates to oncology? How are oncologists going to interpret this, comply with the different mechanisms that are now being mandated under this inevitable bill?
You remember I'm apolitical, so I get to offend everybody now. It's bipartisan, bicameral. So, you know, the SGR is the sword of Damocles hanging over every doctor who takes care of patients, oncology patients especially. So everybody's hoping for a solution. I think what's been proposed is really not a very good solution. That's my opinion. It's not Aetna's opinion, my opinion. Why? First of all, there are, to my reading, and I'm not an expert, the first component is quality reporting. So, you know, PQRS has been around a long time in some modality, format, whatever. And doctors generally didn't do it, right? They didn't do it because, A, there was no significant reward and no significant penalty. But more importantly, they thought it was baloney. Really, the measurements, the things that were measured were stupid. They had nothing to do with quality. And we should ask the patients what they think about those measures, because they don't reflect quality by any human being's definition. So now there's this race. Who's going to be in charge of the quality measures, right? ASCO wants to be in charge. Everyone wants to be in charge, except nobody really can define quality, and then nobody really has a methodology for reporting it. So the quality problem is a problem. And the alternative payment methodology is an even bigger problem, because nobody really knows what an alternative payment method is, right? So it might be what John does, but then again, John is kind of like the Meriwether Lewis of the oncology patient center medical home, or maybe he's the Sacagawea, I don't know. But he's the pioneer at any rate. And so you cannot ask practices who do not have the capability of implementing process reform to accept that, or accept a significant decrement in their income. So let's say they say, we cannot do it. And remember, you have to have 25% of your Medicare beneficiaries in an APM, ultimately, for this to work. That's a lot of people. So let's say you can't do it. What's going to happen? You're going to get paid less money. So what's going to happen? You're going to go work for the hospital, because it's hard enough now. And if you make it worse, then people will say, I'm going to work for the hospital. I don't have to deal with this.
Any questions from the audience? Yeah. Not yet.
Dr. Kulud, am I going to pronounce it right?
Call me Mike.
Okay. Your colleague Randall Krakauer is easier for me to pronounce. Anyway, when we hear from Dr. Rubel and Dr. Sprandio about these, the out-of-pocket costs are just too high, and patients are unable to pay, and they're not getting treatment. As someone from a payer side, do you not then get concerned that by deferring treatment, the cost to you will actually be greater as a result of them not adhering to appropriate treatment initially? Shouldn't that drive your reform?
Costs are higher to us no matter how you cut it. So let's think about this for a second. out-of-pocket max on the exchange, $63.50 for an individual. Now, to us, that doesn't sound like a lot of money, but I will grant you it's a lot of money. But anything over and above $63.50, we pay for it. So if an oral oncolytic is $10,000 a month, right? I don't care if you're gold, silver, platinum, copper, brown, it doesn't make any difference. You get above that number. Now, so now we have that. So that's number one. Number two is, yes, you have an issue of noncompliance, because what happens is the first time you go to get that prescription filled, you pay your deductible, $1,500 or whatever the heck it is. So I can easily write a check for $1,500. I'm not bragging, but it's true. I've been a doctor for a long time. You could probably write a check for $1,500. A lot of people can't write a check for $1,500. And that claim hits the minute you go to the pharmacy. That minute. So it's a problem. There's some cost shifting. Now there's a second component of this. And there's something I wanted to ask the congressman and I didn't get a chance. So outside of government payment, who pays for most of the health care in this country? Well, it's the employers, right? So let me tell you, they're paying attention. And I've learned a lot of things in my 1 year in the health plan, and I've attended plan sponsors meetings, and they do this thing called high-cost claimants. They sit and they talk about everybody who costs more than $50,000 or $100,000. Guess what? They're all cancer patients. The degree of understanding and sophistication.
I think the AOL people say there's a couple babies involved too.
Yeah. That's true, but only for AOL. Yeah. So all I'm saying to you is this: the employers are paying for it too, and there's a trickle-down effect. If the employers have to pay for it, it is a zero-sum game. In fact, it's not just a zero-sum game; it has to be a negative game going forward.
I'd love to ask you a question, Mike, because I did a study once where I asked oncologists, suppose there's a new cancer drug that costs $50,000 more than standard of care. How much longer would someone have to live for you to prescribe it? No cost to the patient. I guess like 3 months, 6 months were the main answers. Separate group of oncologists, same question, except I said the drug was $125,000 more than the standard one. 3 months or 6 months, same answers. They were price insensitive. So if oncologists aren't paying attention to the costs, if patients, whatever those two costs are, they're going to get to their out-of-pocket maximum anyway. Can insurance companies say no? I mean, is it just impossible for an insurance company to say we're not going to pay that price for that treatment?
You really want to get me into trouble, don't you? People tweet when I say stuff like that. So,
he already violated HIPAA. It's okay.
That's it. Yeah, the police are outside waiting for you. The answer is no. I don't think in today's world that the insurance companies can say no. So, I used to say, I just go to meetings with oncologists. I don't know anybody else. And we all think the same way. And then when I went to the health plan, I had to talk to internists. Holy smokes, do they look at our world as distorted? It's still a relatively small portion of the entire spend. So oncology makes up, I think, 11% of the commercial spend now, although it's less than 1% of the population, the commercial population, and it's going up fast. So I think that there may be actually alternative solutions to saying no. I think that there's been some interesting discussion about value-based reimbursement. So let's say, for example, you wanted to do that really expensive drug. The deal would be, and believe me, pharma would have to be part of this deal. Give it to you for a couple months. It's free. If it works, we'll pay for it. If it don't, we won't. I'm good with that. What's wrong with that? Sounds good to me. The other thing is that it is definitely clear that some of these alternative payment models, bundle reimbursement, are shifting risk to the provider, and they're forcing them to become cost sensitive. And so, for once, the payers won't be the bad guy. I'm not sure that's a great solution, but that is a solution.
Joe, I wanted to ask you about and maybe you can give a better introduction to it than I can, but there was a study that came out this week from RAND about the medical home that was somewhat disappointing. And a lot of the payment reforms predicated on that. You're obviously heavily involved in that. Can you talk a little bit about that study and
Sure. I would start by saying don't be disappointed. Those were the 3-year results of the Southeastern Pennsylvania Primary Care Initiative that included 32 practices. And now there's other data regarding medical home models which are a little more positive. But there's a couple of things that I think actually cause more optimism in the oncology arena regarding this model than in the primary care arena. I'm not surprised that I was a little surprised that the quality metrics didn't move in the right direction a little bit more vigorously, 1 out of 11. And I'm not that surprised about the cost not really being moved either, for a couple of reasons. When you first start talking about transforming practices into a PCMH, there's usually the first reaction from physicians is to ask how many more staff members I need. Do I need care coordinators? Can the insurance company bring in a care coordinator into my practice? Or do I have to hire a care coordinator? So there's additional costs that are overlaid. The way around that, the long-term way around that, is to leverage technology. For example, in my practice with some of the technology we've inserted, I'm the care coordinator for my patients because things are structured. Things are structured and I have visibility to the rest of the physician-led care team. So as time goes on, I do believe the cost of executing that level of care in the primary care arena is going to also leverage technology so that there can be less overhead. And I think that's one of the drivers. The reason why I think that there's an opportunity, and we have shown it within our practice, for saving a significant amount of money in cancer care, is because we treat an older patient population by and large with comorbid conditions and a serious condition, cancer, and we do serious things to them. We cause side effects and symptoms which are fairly predictable. The time frame is fairly predictable. So we have a whole array in cancer care. We have a whole array of potentially avoidable complications that we can pick up early, target, and reduce by making individual physicians accountable for their complications, just in terms of comparative data analysis. So it's a model that I think it really fits very well with cancer care. So I would tell you that I do expect that you're going to hear. I also am aware of things that have happened in that 32 practice pilot since 2011, and there will be more impressive data coming out of that group, but it's not there yet. So I think it's going to work, and not just for oncology, obviously, but for all types of specialty care and for all types of and for primary care. We're working with the NCQA on the patient-centered specialty practice recognition standards, which are broad-based for all specialists. And in Southeastern Pennsylvania, we're inserting oncology-specific components into that. That's part of the study. So I'm very, very optimistic that we can, again, through standardization of process, really change the way that we're executing care. And by the way, one of the things I try to get across, there's always a debate about quality. What is quality? What should we measure? What should we do? Quality isn't just following the NCCN or the Commission on Cancer guidelines. It's how you execute care. The IOM definition from 15 years ago about quality was the likelihood of healthcare services delivered to individuals and populations of increasing the likelihood of desired outcomes based on the current evidence. Okay, so that means how care is executed it can be a measure of quality. And process standards drive consistency in execution. So anyway, we've had a very interesting experience with it. We're trying, we're working with other payers around the country to not just address the changes in quality, but also to even address the out-of-pocket expenses for patients, which I really do believe is a looming crisis. I would say that it's here.
Questions from?
ran the VA medical research program for the last 8 years, so I'm very familiar with the quality indicators and all the issues. And there are two fundamental issues that come up with them that nobody's really solved. One is if you create indicators, people focus on those indicators and may ignore other things. And the other is that you measure what you can measure, not necessarily what's important. And certainly I'm a cardiologist, but in cancer care, obviously a lot of is intangible, although you can measure if somebody's having sex more than 2 years. But I think that there is very little hope that either of those problems will be addressed or solved in the way that oversight is done now. And I wonder if any of you would have any comments on that.
You want to go on the panel?
I think that's a correct and salient observation. So yes, we promote box checking, and B, we measure what we can and not what matters. So it's interesting. I was challenged to come up with the quality metrics that we are trying to employ in our various delivery model pilots. And like a lot of things in life, it actually comes down to a fairly small list. Keeping people out of the ER, keeping people out of the hospital, having a discussion with them about a treatment plan, talking to them about their advanced care wishes, using hospice when appropriate. So those are both process measures which, if there's not evidence for actually enhanced outcome, there's at least a strong case for an enhanced outcome. And so we are, I think, making the perfect the enemy of the good. And if we could just come to a basic understanding of what constitutes quality, reasonable quality, then perhaps we can move forward. Reporting how many people get the CD5 measured on their CLL cells is not a quality measure. It's a PQRS measure.
I just wanted to make a comment that the goal is not perfection. The goal is to begin a transformation of the way that care is delivered. And the foundation of that is process standardization. And it's unique for cardiology. It's different for cardiology than it is for oncology because you really are focusing, your processes are really designed around focusing on potentially avoidable complications and enhancing service. So I've been criticized a little bit over the past couple of years that some of the things that I talk about are more towards the perfect ideal. The PCMH recognition programs that are out there do not ask for perfection. They ask for the beginning of a journey. Even our payer arrangements in southeastern Pennsylvania, we structured them in a way where they can be applied or offered to other practices who may take a year and a half for the journey or may take 6 months if they have enough of sophisticated electronic infrastructure in place. So it's not so much that there's no perfect ideal. There's the steps, initial steps in making changes in the way that care is executed, and care execution again falls under the domain of the IOM definition of quality, and a lot of oncologists have a hard time grasping that.
Do we have any other questions from the group right now? Oh, please.
Thanks. My name is Jeff Nadell. I'm here from the Brookings Institution and have a question, kind of feeds a little bit off of Dr. Kologie's comment earlier about how there are some small four-doc practices in Fargo who aren't really ready to start moving towards these alternative payment models. And I think that that's likely true because there are a lot of these practices that don't even have electronic medical records and aren't ready to start picking up the types of practice transformations that Dr. Sprandio has done and is talking about. But I'm starting medical school in the fall and thinking towards when I'm eventually going to be wanting to practice. I want to be likely going to a place where these practices are ready to start implementing electronic medical records, and they're going to be in a place where, whether or not anything happens with regards to movement away from fee-for-service, they're going to be ready to start addressing contemporary challenges in healthcare. So how do you start moving these practices that aren't anywhere close to being there to a place where if community oncology wants to survive with a new workforce who really is going to be looking for these types of innovations, that they're going to be able to do that.
So I have a slightly paternalistic view of this. We are very much in favor of the use of clinical decision support tools, which are web-based and allow practice to start getting the habit of at least keeping track of what they're doing, physician-level reporting. And we're trying to build enabling technologies within Aetna that we can offer free of charge to the practices to help them transform. So I have a program that's going live tomorrow, which is a virtual patient navigator. And I think that ultimately this space is actually going to get filled by entities in the commercial realm. So I think there's going to be companies that will be able to come in and help whip a practice into shape. Of course, you have to have an electronic health record. You cannot do this with an electronic health record. Forget about it. And unfortunately, only about 60% of oncologists are on EHRs right now. I'm not even sure that's an accurate number. You'd be surprised how hard it is to
Do you know what percentage of my sense is that the newly trained physicians are going, they're not going to a random sample of practices. They're tending to end up in larger practices or hospital-based.
I honestly don't know whether those statistics exist, and based on ASCO's recent attempt to even count the number of oncologists in America, I doubt they exist.
The challenge with the companies that can provide the practice management support tools to the independent practices, the old practice management model, I think, is that the practices are capital constrained, so they can't afford to bring in the service. The only way to underwrite it then is for the practice management company to come in with capital, its own capital, and share in the risk and make the money by sharing the risk.
And that's what we've done.
But no, you've done it because you guys have a pool of capital to do it. It doesn't seem to be that there's entrepreneurial models. No one's putting money into that right now. I think people are scared to make those investments. I don't see it happening a lot. I mean, I know.
So I know of at least two examples where it's happening, and we're not bringing a lot of capital to the deal because it's very hard for us to generate capital up front because Aetna has a lot of self-insured business and they don't want to pay for something that's not proven. But the fact of the matter is these are big companies that are coming to the table with this enablement technology, and they have been to this point willing to enter into risk-sharing agreements where they get paid on a percentage of the shared savings.
Right. Peter, you challenged the congressman about standardization in healthcare and at the primary care level. It's there's obviously, and I know you'd agree with this, there's a difference between primary care medicine, standardizing practice patterns in primary care versus oncology. We're heading to an environment where a lot of the practice of oncology is becoming more personalized because we're learning more about tumor types and we're directing therapies towards specific kinds of profiles of patients rather than broad categories. How do you rationalize that? Because what I think I see happening, and you guys are closer to this than me, is that a lot of the standardization seems to be veering around the adoption of the technology and the physicians, again, a choice of the technology rather than standardization around sort of the care of the cancer patient, but allowing discretion when it comes to the choice of the technology, which is what you'd probably want to personalize. And maybe I didn't ask it well.
No, I don't know. I mean, I don't know in oncology. I don't know what VA does in oncology settings, for example. I would expect they negotiate harder on price, and that they have probably a tiered, ordered formulary for certain things. But I would be stunned if you have a genetic test that proves this person's a responder to this treatment that they would not take that into account. But
well, where do you
guys know?
John, you're in an environment where you're trying to roll out appropriate standardization. Where do you see it being implemented?
I'm sorry, what part of it?
Where you see, the types of things that Peter talked about, where you're seeing more standardization of care versus affording more flexibility to the provider.
First of all, you need flexibility in treating cancer patients because we're responsible for what we do, how we affect their comorbid conditions. So it's not all about the drugs. We need flexibility in terms of therapeutic selection. The standardization that I talk about is process standardization. And there are rich in treatment guidelines, but it's really not, the cancer spend is really not all about the drugs. 22% of the cost of cancer care is wrapped up in drugs. The rest is not. So You need flexibility. Practicing the art of medicine is something that every physician, that's why we went to medical school. We wanted to make complex medical decisions and have personal relationships with patients. So flexibility in terms of therapeutic decision-making is desired. The insertion of pathway vendors is often a barrier to the practicing oncologist.
And I think it's a matter of how much flexibility and how much constraint in setting that balance. I mean, medical markets just aren't, the medical decision-making is not as straightforward as doctors know what is best. I mean, that's just not true. And I'll give you an example of one of the people we studied a conversation between patients and doctors talking about costs. Patient with metastatic breast cancer can't pay for OxyContin. It's so expensive. The doctor's response, well, you should try to take that pill less often then, so it'll cost you less. Not, there's generic, long-acting narcotics that would treat your pain just as well. And I think if in a VA setting, that patient would not have had OxyContin as an alternative. Again, it's not all just about drugs. We need flexibility, but sometimes you need constraint, because that doctor, why is the system unconstrained from not going in an orderly, sensible fashion on narcotic treatment?
Questions from?
I'm curious, it was discussed earlier about the Part D, some of the regulatory propositions put forward, and one of the questions, I believe, was about the transparency of prescription data. And just for what you just noted, I would think if provider down to the provider level, prescription data were publicly available, that could be mined either for research or even commercial things, that would have an impact on those kinds of issues you just outlined. Could you comment on that? Would that be too perverse if that data was just in the public domain?
Well, it is available now. It's just available for a fee. You can get provider level prescribing data from IMS. I think the difference is going to be that you're going to have it down available to anyone who qualifies as a researcher, which will be a lot of people. And so I suspect it's going to have some positive impact on providing discipline in the system, but a lot of nefarious uses as well, where physicians will be objectified in certain ways. And you're already starting to see it. I mean, you're already starting to see if a doctor took a $4,000 honorarium from a drug company and then prescribed a drug at a 5% more rate than his partner. There's an article in a local newspaper about it. So I'm not sure it's going to be all positive. I don't know what your thoughts are.
I agree. I don't know the balance. I don't.
Yeah. Any other questions from? So I think we're wrapping up. I want to just close with one question from Michael, and maybe hopefully the rest of the panel can address it. We're on the cusp of passing this bipartisan SGR bill. I think it seems there's a certain inevitability to this legislation. Hopefully we can work out the kinks in the implementing regs. Michael, what do you think? You're on the front lines now of implementing systems, rules, changes across providers. What do you think the pace of change is going to be from these payment reforms? Have we set realistic expectations here in Washington, or do you think we're going to end up somewhat disappointed about the outcomes?
So what are the expectations here in Washington? So there's this illusion that CMS is like talking to me or talking to people I work with.
I think
as far as I know, that's not occurring.
I mean, maybe someone from the audience can comment. I think there's a sense that there's going to be more rapid changes in the delivery model, and we're going to see, improvements in outcomes and economic savings as a result of the things that are getting implemented, not just under the SGR fix, but also under the Affordable Care Act, because after all, a lot of these payment reforms are things that either were codified in the ACA or even before that in the MMA. So what do you see? I mean, how long is it going to take for some of these new care models, medical homes, forms of bundling, capitation to actually have an impact on quality and delivery of care, if they're going to at all?
3 to 5 years.
Okay, that's pretty quick. Do you have
I do have some optimism that the appropriate changes in payment methodology will promote the right activities. And I do think that we're going to see positive changes in both cost and quality. And I don't think that the level of electronic infrastructure is going to be the ultimate barrier. So I think that I think we will see changes. We could see changes in structured programs, within a year, I would think. The more unstructured they are, it'll be 3 to 4 years probably.
And I know much less than anybody here, but I'd say that one of the interesting things is cost is a lot easier to measure and assess than quality, and several people have made that point. And that's, so the worry here is we're going to get a lot more about the cost side, and if we don't also look at quality, that's a risk. So.
Well, I want to thank the panel with an excellent discussion. Turn it over to Shelley for the next panel. Thanks a lot.
Hi, how are you?
Hi, so I'm Shelley Fold-Nasso with the National Coalition for Cancer Survivorship. First, I just want to thank Scott Gottlieb for partnering with us on hosting this symposium today, and for the staff at AEI who have helped us put this together. Last year, NCCS named a group of cancer policy advisors who we turned to help us, think through some of the policy issues that we're working on as it relates to quality cancer care for patients. And Scott is one of those cancer policy advisors, and we're really grateful to him for his support. And also, Dr. Cox and Dr. Koloje are also some of our cancer policy advisors, so we're really grateful to them. I also want to just, in full disclosure, mention that Dr. Sprandio talked about his PCORI-funded grant with NCQA, and we're also a partner on that grant, and really pleased to be working with him on evaluating the impact of patient-centered oncology care. So now I'm going to briefly introduce our panelists. You have their full bio, so I won't spend too much time, and then let them give some opening comments. We have Lily Shockney, who has the longest email signature of anybody I've ever met. She has many, many titles, but my favorite one is University Distinguished Service Associate Professor of Breast Cancer. She's a nurse and a cancer survivor, and she directs the Johns Hopkins Breast Cancer and Survivorship Programs. Dr. Cox is an oncologist from my hometown of Dallas and has been on the forefront of cancer care delivery reform, both in his own practice and in his leadership as editor of the Journal of Oncology Practice. In a recent webinar that we did together on quality cancer care, he described himself as a frustrated, optimistic, liberal, red state oncologist facing high noon. So it's perfectly appropriate that he's here at AEI today talking. And then Stephanie Dyson is the Senior Director of Public Policy and Reimbursement for Genentech. She's also a nurse by training and has held numerous leadership roles at CMS. So she has a unique perspective, serving as both a healthcare provider, a payer, and now as a health policy expert with Genentech. So thank you all for being here, and I'm going to let Lily start.
Well, thank you for asking for us to be here as well. So I'm at Johns Hopkins. I've been there almost forever. I've been there more than 30 years. And over that time, I have been an oncology nurse. I've been an oncology nurse in and out for over 40 years, but 30 years in a very concentrated way. I sort of burned out, and I was taking care of glioblastoma patients, so very high mortality, needless to say. And the president of the hospital asked me if I would become the director for performance improvement, utilization management, and risk management. And I should have said no, but I didn't. And so I filled that role for 10 years. During that time, I got breast cancer twice. And yes, I do think there's a connection also. And that just a few years ago, I landed in the hands of GYN Oncology. So I'm working my way down. I have figured that much out. So I think if I get toe cancer, then I can stop worrying. I have been very involved with survivorship care, and I am responsible as the director of our breast center, but also a second position as director for our cancer survivorship programs for the institution. And we've held focus groups with breast cancer survivors, with oncologists, surgical oncology, medical oncology, radiation oncology, who take care of breast cancer patients, and also PCPs who are beginning to inherit back their breast cancer survivors. And there were several things that came out of that that add to my concern about where we are with healthcare economics. There's already a shortage of PCPs, so now we're asking PCPs to do even more when there are less of them and less time to do it. And they expressed very vocally, I didn't have training in medical school about cancer survivorship. You people are supposed to keep these patients and not send them back to us. We do not consider that a chronic disease, and that's what we learned about. So please keep them. And the oncology team said, we would love to keep them. And I said, but you can't, because you can't put 10 pounds of salt in the 5-pound bag. So the oncology team said, well, we're going to miss seeing these patients. We may see 5 newly diagnosed today. Each of those women are saying, oh my God, am I going to lose my hair, lose my breast, and might I die? And you scrape them off of the ceiling with a big spatula, calm them down, and spend an hour or more with them talking about what lies ahead. But sprinkled in between there are the patients coming back who are the survivors for their routine follow-up. A year, 2 years, 5 years, 10 years. I met one that was 19 years. And they really don't need to be seen. They know it. Oncology knows it. But it's a social visit and a good visit, because that's that warm fuzzy for the oncologist. And the doc said if we scoop all of them up and take them away from them, they don't know if they even want to stay in this business. If we're going to replace them with 2 or 3 more newly diagnosed, what do you mean I'm going to lose my hair, lose my breast, and I still might die? And the patients didn't want to let it go either. So when I looked at all of this and I thought, we've got to do this differently. One thing we have to do is prepare patients from the moment of diagnosis so they know what the expectations are. And we've got to do some training, and we've got to do that quickly for internal medicine, as well as for oncologists as to how to wean away for themselves and for their patient.
Thanks, Lily. John?
Oh, I appreciate being on this panel, and I'm amazed at the first group of speakers who, I must admit, stole a little bit of what I would like to have beat the table on. I've been in practice for over 30 years in medical oncology and started as a solo practitioner after leaving an short academic career, and then slowly over time have accumulated partners. I accumulated one partner and then 2, and then joined a rather large group, one of the super oncology groups, super groups as it's called in demographic terms, Texas Oncology. We have close to 380 oncology providers, including surgeons, radiation oncologists, medical oncologists, gen oncologists. My current practice setting, I'm in a urban hospital. My primary hospital is a safety net hospital, a very heterogeneous population of patients with 10 medical oncologists, 2 rad oncs, 1 breast surgeon, and a gen onc, and we just had a small group of urologists join us. So it's a quite different practice than a small practice. I have a lot of support from my group. We have a management agreement with U.S. Oncology that provides us with professional support. And I say all this because referencing Shelley talked about the title of my description of myself, is a liberal in a red state and quite frustrated. Shelley also asked a question of me in preparation for this panel about whether or not patients or whether or not oncologists feel the urgency of change needed that patients do. And that really resonated with me, because in our state, in my practice state, we are the wild, wild west. There's no CON. We have you may have heard about Texas tort reform. Talking to Dr. Price's comments earlier, we're probably the most friendly physician-oriented state in terms of litigation relief. And because of that, we have physicians rushing to our state. It's also no income tax, and there is very little encumbrance on a physician or a physician group creating whatever economic model they wish to create. And what I have seen happen over my career is the silos of care get structured very highly. And one could argue it's the economic system that has at least supported this, if not promoted it. And so when I sit down and talk to patients, what Mike talked about as was iterated in the IOM report about the crisis of delivering care to a cancer patient is so true. They see 6 or 7 providers. Nobody is coordinating with anyone. Often MRIs or CTs or diagnostic studies are done in freestanding centers to which it's very difficult for me to get reports, much less get the images. So there's more duplication of services. Patients are extremely frustrated in that, and I hear it more and more of my colleagues as being extremely frustrated. So where do we go? I have had just one is St. John, as I call him, John Sprandio, has remarkable work in helping show how processes and process improvement in a given office can help build care coordination bridges that makes it more fun to practice. He didn't talk about this, but his partners actually have greater satisfaction, and it helps on some of that burnout. I dare say his patients experience that. So I look to how can we improve in our practice building those bridges. For that reason, I've just, taking all the support of my large group, tried to participate as a patient-centered specialty recognition practice through that program of NCQA. We will scrape by to probably be the primary level as we're learning to do that. It's incredibly challenging to learn how to do what John has done in practices. I see that as a good thing, that it's a challenge. The last thing I wanted to mention is how to break down those silos. I have been a bit participant in our hospital's Medicare Shared Savings ACO. And it's given me a little sense of what risk in the game can do. There's a very small risk pool of money, but it's what that participation in that small ACO project brought diverse providers, the primary care docs, the surgeons, the rad-oncs, cardiologists, the radiologists, to a table. And for the first time in my memory, we sat around a table and began talking about care delivery issues and this repetitive diagnostic environment and how we share information. So it has impressed me that a little bit of risk really can be an engine for cultural behavioral changes. I think that will trickle down to patient experience and engagement in our practice if those patients who have multiple providers, if we can begin to develop structures that we talk to one another. I ramble a bit, but as I was taking notes today, I just found myself being a little bit like Horshack, wanting to raise my hand and comment about a lot of it.
Thanks. Not many of us know who Horshack is, so dating ourselves. I love the idea that we have two nurses flanking a physician here, sort of like in the real practice. Good morning, everyone. Stephanie Dyson. As Shelley stated, I'm a registered nurse by background. And when I left the clinical setting, I worked at Ernst & Young as a consultant, then to CMS, working with Scott and then Dr. McClellan for implementation of Part D, amongst other things. From CMS to DeVito once the bundle was implemented, and then doing sort of the high-risk demos, and then to Genentech. And I think that concentric circle has really prepared me for the environment that we're working with within Genentech. So we are the largest and the founder of the biotech industry. Genentech's a biopharmaceutical company. We have a very large portfolio. We're responsible for over 20% of the Part B, as in boy, spend for Medicare and likely commercial payers as well. I'm very proud as a registered nurse, and then two, leading the policy team within Genentech. We make both small and large molecule medicines. We make medicines that help treat cancers that patients had that were once death sentences. We help make medicines that allow people to see. We help make medicines that, after people have strokes, allow them to walk and talk again. And with that comes a huge responsibility when we're thinking about the impact on patients, the reimbursement system, the state of oncology care. We have an onus to ensure that we have the ability to very clearly and succinctly articulate the value of our medicines. And one of the ways in which we do that is through personalized medicine and personalized health care. Because we think that when we have the ability to look at patient heterogeneity and target care towards patients and ensure that those resources are used appropriately, that's our responsibility within the healthcare system. And that's one of the ways as a stakeholder within oncology care that we can do our part as we think about sort of the current state and then how we like to move within 3 to 5 years. And I do agree with the previous panelists that stated that we're looking at sort of those large changes within the 3 to 5 year window. So thank you.
Thanks. So Stephanie, from your past experience with bundle payment mechanisms in the end-stage renal disease area, what are the lessons learned that can be applied to the payment reform for cancer, and what do we need to be concerned about?
Oh, very good question. So I would say, what did CMS, if you will, do well? I would say that they ensured that there was a transition. They ensured that there was a quality metric sort of attributed to the system. And also, they ensured that it was a composite rate, and then other drugs and items and services were sort of transitioned in. I would call everyone's attention to the recent JAMA article on medical homes that said one size does not fit all. So when we think about bundling and we think about how we move forward, I would just want to caution and emphasize that the devil is really in the details. In the ESRD sector, what they did was focus on the bundle at the dialysis center, and it was an acute focus on the pharma utilization within that bundle. But over 40% of the costs for ESRD patients are at the hospital setting. So I think we have to ensure that we have a system, as was stated earlier, that allows innovation, that ensures flexibility, one that understands that payer mix, patient individuality does really matter, and the ability to ensure that there's a dynamic system. So how do we take those lessons learned? I don't think we should be discouraged by the ISRD bundle or by sort of that first report out on medical homes, but I do think that we have to ensure that we take those lessons learned and apply them on a go-forward basis.
Okay. So I was really struck by the study that Dr. Ubel talked about, where the patient's decision-making was based solely on what the physician said and not really factoring in patient preferences. And I know Lily's talked a lot about her work with patients at the beginning of the treatment decision-making process, and really ferreting out kind of what their goals are, what their preferences are, how they want to live their life. And you know, that's something that's very important to us at NCCS. We've consistently advocated for cancer care planning, and we've created a new tool that we have available that really provides patients with some of those questions to ask, and also a way to talk about their preferences with their patient, with their doctor at the beginning of that decision-making process. I've said before that everybody should have a Lily, because when you talk about what you do with patients and how you help them through that process, I feel like everyone should have that, and it makes me sad when I know of a family friend who died recently who needed a Lily and didn't have that. I'm just wondering, how do you do that? What is important to you in that decision-making process with the patients, and both Dr. Cox and Lily? I'd love to hear from you on that.
Thank you so much. So when a patient comes in who's newly diagnosed, and I'm in the breast cancer arena as a clinician seeing those patients, one of the very first things that I ask is, before you heard those words earlier this week that you were diagnosed with breast cancer, what were your life goals? Commonly, the patient will say, it doesn't matter, just save my life. And I'll say, it does matter, and I want to know what they were. Sometimes people don't think about what their life goals are unless you prompt them. So I may say, you're 35 years old. I see that you have been recently married. Are you planning to have a family? Yeah, we were hoping to start a family in the next year or two. Well, that sounds like a life goal, and I think that we need to figure out how we can make sure that can still happen, though it may happen maybe 2 to 3 years from now, by referring you for fertility preservation, because you're going to be getting chemotherapy drugs that may take away that life goal. Tell me more about your life goals. What kind of work do you do? What are your hobbies? What gives you joy? I'm studying to be a concert pianist. Probably should avoid giving you drugs that's going to give you peripheral neuropathy. So let me make sure your medical oncologist is aware of that, so again, we can retain that life goal. The same also applies for those with metastatic disease. I ask them what are their life goals. Because they're going to lose their life to this disease doesn't mean that they still don't have things that they wish they could be here for or could still make happen. One of the things that I do with patients, not just with metastatic breast, but other types of metastatic cancers as well, is to help them in fulfilling a hope in an alternative way. So if a patient says to me, I have a 4-year-old daughter and I want to see her start kindergarten, that may be able to happen. But I have a 10-year-old daughter and I want to be there when she gets married. That probably isn't going to happen. So an alternative way of fulfilling that kind of hope is that we give patients cards. They select them out of tons of boxes that I've gotten of having people donate cards. Cards for birthdays, cards for communion, bar mitzvah. We even have cards when you learn how to drive your car, graduate from high school, college, when you get married, when you have your first child. What does that patient want to tell her child on that day? I give my children and grandchildren cards all the time, but I usually just write love mom in it, and I don't write what I'm thinking because I figure I'm going to see them, but I still don't say it. So I actually have told patients, you're doing a better job of instilling your values in your children than probably I am, who's here. I had a phone call from a young woman, 24-year-old woman, who told me that she had never met me, that her mother died when she was 10, and that I was very involved with her care. And she said every birthday there was a card there from my mother. She said when I got my driver's license, she wrote in there, don't drive like your father. And she said, when I graduated, there was a card. She said, 3 weeks ago, I got married. And she said, when my aunt, my maternal aunt, put my veil on my head, she handed me a card from my mother. And she said, my mother had written in it, I'm sure that you have very carefully selected a man worthy of you spending the rest of your life with him. Her advice was never go to bed angry with one another. And then she wrote at the bottom, P.S., when your dad lifts your veil and kisses your right cheek, you will feel me kiss your left. And she said, Miss Lilly, I'm calling to tell you I felt my mother's kiss. Thank you for arranging for her to be at my wedding. So I know this works. I have every bit of faith in it because I get those types of communications again and again. I also believe in helping patients all the way through to the end of their treatment and beyond, because they need support, not just while they're in the thick of it, but also afterwards, because this is certainly a life-altering experience. I want to learn from the patients, what is it that's important to them? I had a patient not long ago who, she had a tiny tumor. The doctor said, you're an excellent candidate for lumpectomy. She said, I'm going to have bilateral mastectomies or I'm going to have nothing. So the doctor said, stay in here with her and explain to her that she's not improving her survival by doing these big surgeries, which was an assumption on the part of that doctor. So I said, it sounds to me like you already made a decision before you came in here. You wanted to have bilateral mastectomies. Help me understand how you reached that conclusion. She said, I was an incest victim as a child. I think that my breasts are just poison to me. I now have a legitimate reason to get rid of them, and I don't have to explain it to anybody. Good grief. So our patients bring a lot of heartache and garbage and whatever's happened to them in their life with them when they end up with any kind of a cancer diagnoses. We need to know our patient well beyond their pathology. We look at their pathology report. Okay, this treatment is what I'm going to do. I'm saying not until you find out who she is and what's important to her and what gives her joy, and where does she see herself. I have been responsible for 2 husbandectomies, and I'm hoping those men do not know. I'm still praying that they don't know where I live. Those are the life goals I learned behind closed doors for 2 of my patients. Absolutely. And for patients with metastatic disease, we still treat for treatment's sake, which is a big mistake. I ask patients at our metastatic retreats that we hold with them, not who, but how will the decision be made when it's time to stop treatment? The patient will say, my oncologist will tell me. I've done focus group with oncologists. How will the decision be made? Patient will tell me. This is like a bad marriage because people aren't talking. Patients even tell me they go to more trouble to look good on the day they go for their visit, get their wig on straight, extra makeup, look sharp. So the doctor will say, you look pretty good, which is what she wants to hear, but she's feeling worse. And it's like buffering. So he said, I think we can continue as we're going. Oh, good, thank God. But that is not what should have probably happened. Quite frankly, that shouldn't have been what the game plan was. And yet that's what she goes out the door with. We'll continue on this treatment or we'll move on to yet another treatment because you look so good. I just buried my dad a couple weeks ago from cancer. And let me tell you, I wanted to make sure that he experienced a good death. His view of palliative care was they're going to stick me in a room and maybe euthanize me or just let me just slowly, rot away, but I will be abandoned is what he interpreted. So when I made him the palliative care consult appointment, I told our doctor for palliative care, take your badge off because it says palliative care. I'm introducing you as the quality of life coach for Johns Hopkins Cancer Center. And I said, do you know anything about farming? He said, I grew up on a goat farm. I said, perfect. I said, my father is a farmer. He's the patriarch for farmers on the Eastern Shore. Do you own anything John Deere? Yes, I have a riding lawnmower and I have a hat. I said, put the hat on. So when I bring my dad in there in the wheelchair, he bonds with you quickly. Otherwise, he's not going to trust you. Father was very distrustful of almost everybody. So they related right away. And the doctor asked him, tell me your pain level. He had a vertebral fracture from coughing. Then he said, tell me 3 things that give you joy or gave you joy before this fracture happened and you're in so much pain. And he says, I love spending time with my great-grandchildren that are very little and very funny to listen to. I still want to do what he called his wheeling and dealing. He did huge farm loans for young farmers that otherwise would not get to be farmers. And he said, I still want to be able to ride the tractor, even if it's only for 30 minutes when I'm up to it. I said, yes, smelling diesel fuel is part of his treatment, I think. So he said, those goals that are our goals, we want to get you back to doing that. And with the nerve blocks and getting him off of OxyContin, in 2 weeks, my dad was back out on the tractor. I took a picture of him. It was amazing. I know that if I hadn't done what I did in getting him in there to see Tom Smith, he would have died a whole lot quicker, whole lot. So that was 2 years ago. Discussions had happened with him already of, do you want to travel the hospice road? He goes, I don't think so. I still want to be a farmer. So knowing what was important to him gave him joy. And he was only off the tractor for 2 months before he passed. But there's other 2 things he was still doing up to his last week of death.
I have vowed never to listen to Lily talk without a Kleenex handy, but at least she injects humor into it. So, Dr. Cox, do you have a Lily to help you do these kinds of things?
I don't, and
I'm
thinking there, first of all, I need a Lily, you know, and I got to suspect that many people in this audience are thinking this too. A couple of things struck me as I listened to Lily is, first of all, the emphasis that's been said several times about care delivery is a team sport. And one of the problems that I reflect back on the fee-for-service kind of windmill we're on is that the team sport often isn't recognized. So I do think this is maybe my core absolute optimism about considering alternative payment mechanisms that recognize a care team where there could be a lot more Lily's voices. The second thing that I thought of while you were speaking was something Tom Price said, because often I hear, in fact, I think there's even some research data that younger docs are probably more compliant to professional guidelines and the like. I love the fact that he valued physicians 55 to 70. I sort of like that. But as I listened to you, Lily, I realized, and I realize this now as I enter an exam room, one of the joys that we have, the privileges we're given, is the stories we get to share with patients. And I'm old now, and I've slowed down a little bit, and I spend more time talking about stories. And there's more than one example, just like you've said, where listening to the story made me change what treatment recommendations were made, or at least forced conversations. And I know that does not happen in some of my busier, younger, the young professionals that have just joined our practice. So I wish, I don't know quite how to put this in a package, but I know it has to include team. It has to have a reimbursement system that honors team. And then I do hope, I'm a graduate of Texas A&M. The vet school is big on cloning cats and dogs and horses and stuff. I don't know, Lily, but I might like to send you down there and we just bank you away for a while.
Thank you.
So, Dr. Cox, I have another question for you. So, Dr. Sprandio talked a lot about process standardization, and I was thinking you were probably wishing you were on that panel so you could talk about it. I'd love to hear your reaction to those discussions. We talked a lot about flexibility versus guidelines, and then on the treatment side, but also the process standardization.
Well, and John must get used to this whenever I'm around him, because he has a lot to teach us, and I agree with him. I've maybe wouldn't have agreed with him several years ago, but especially over the last year and a half of dealing with the NCQA specialty recognition project we've been involved in, is it's just that had provided our practice with a roadmap of how to deal with problems we have literally argued about in physician meetings for years. And so I began to see, you know, from a physician, we do hit these recognition programs that deal with standards. A lot of times when I deal with my institution going through the American College of Surgeons cancer program, or the JCH coming into the organization, and we physicians belittle that process standard oriented approach. But I saw when it came back to my practice is it allowed for the physicians in my practice, at least a subset of them, to focus on the standard and talk about how we delivered care that dealt with that particular issue, patient education, and allowed us to begin standardizing stuff. Now, we've just begun the journey that John's been on for, what, 15 years, 10 years? And I am convinced that that's an exportable skill. It is not the end. It is the process on which you begin to take on. I guess one of the things that disappointed me about that recent RAND part was also they evaluated the number of those practices that had true quality improvement projects, and they were disappointingly low. And yet I look at this process and it looks like it demands quality improvement cycles to be occurring in your practice routinely. Long-winded answer to say, I like it. I like process.
So Stephanie, since you have this perspective as, you know, having been on the provider side, the payer side, and now in industry, how do you envision kind of reconciling the interests of each of those sectors in the best interest of cancer patients when it comes to payment?
Yeah, interestingly, so Genentech's approach specifically, we do put patients in sort of the center of our discussions, and when we think about science and how our products impact patients, that's important to us. I have a couple of colleagues here today, and one of which, Sonali Chopra, works with our patient advocacy team, because we always try to think about what's the intrinsic value to patients and how do we participate in those discussions or in that processes. Even when you think about our portfolio and our medicines, we think about those products that are personalized, that have targeted therapies. Like, how do we consider the unique value of the patient, but also ensure that we infuse the value of the science and the medicine? And talk about sort of the entire system as we've been discussing as well. So we have a product, Kadcyla, that's used for a very aggressive form of breast cancer, HER2-positive breast cancer. And this product is amazing because what it does is it precludes the needs, it obviates the need for chemotherapy. So it delivers the chemotherapy within the biologic itself. So that's high quality, high value for patients, for the system, and then for payers. And we think that those sort of groundbreaking, if you will, changes along with the incremental changes in science and innovation is what really matters. So it's really a collective, like as stakeholders, we all have to realize that we're each accountable. And then you have to come to the table with those clear decisions and that clear sense of accountability so that you have the ability to, I would say, contribute to what the overall sort of change would be. It's going to be incremental. I don't think we have, again, a one-size-fits-all. I don't think there's a magic bundle or a magic episode of care or a magic APM model that's going to change sort of the face of oncology care. I think it's going to be sort of the collaborative and the continuum of what we're learning today. Like, we're in the midst of payment and delivery reform. We just don't have sort of the magic bullet or that one single answer.
Mm-hmm. So I have more questions, but I want to give the audience a chance. Does anybody have a question they want to pose? Dina?
Thank you. Dina Darlington, Onyx Pharmaceuticals. So Dr. Cox, I heard you indicate that you really appreciated the standardization that you've been working with over the past year, as well as appreciate the lovely stories that Lily shared with us and the individuality that occurs within those stories for various patients. How do you incorporate that flexibility to have the individuality in that standardization of process?
Actually, I don't think there's a cross purposes there at all. I think, in fact, it's just the opposite. When I think about the standardization of care processes and ongoing in our practice, I hope what is the end, or at least the transit points, is that it emphasizes a mechanism where those stories can be heard. And we've got to develop more team approach. Right now, our office, just like I think many oncology offices, is really keyed off of the physician visit. The doc has to touch, it's up to the doc to listen, to hear the story. And often that there isn't enough time in that visit to expand on it. If our processes can be improved, where we build in that there is always some time with a nurse or with an assistant, a voice, or a standard process where we engage. One of the things we're looking at is providing to certain of our key referral physicians some resources we want them to give to the patient before they come to our office. One of those resources comes from cancer.net, and NCCS, I think, has something similar that has questions you want to ask your doctor. Mm-hmm. So if we can put more questions, more prompts in the patient's view, and it's not as expansive as having Lily sit there, but it may prompt that doc or that to slow down a little bit and hear the story a little bit. So I see standardization of simple processes could really enhance having that voice heard rather than constricting it all. In fact, I think if you leave it as it is, it's more and more constricted.
Are there any other questions, Dr. Cloje?
Scott and I talked before the meeting this morning, and I thought he was going to ask me what kept me up at night. So one of the things that keeps me up at night is we're going to go through all this reform, and the patients are going to say, we don't like this. We just don't like this. And short of John's plan to send you to Texas, Lily, what can we do to avoid that? Shelley? Lily?
Well, I think one key is having patients at the table when these discussions are happening about what kind of payment models that we want to see. And that's why, this is a big focus for NCCS and some of our other patient advocates who are here in the room. And I think, one question I have is how can patient advocates be an effective voice at the table in making these decisions about what kind of payment reforms need to happen so that we can make sure the patient voice is heard. We have put together kind of some principles for what we think needs to be in a payment reform model, and that we will use to sort of evaluate different models that are being proposed and how patient-centered are they. And we've been working on that, are going to be using that to evaluate different models that are in place. But I would be interested in any feedback you all have about how we as advocates and the other advocates who are here in the room can represent that patient voice at the table when these models are being discussed.
Yeah, I'll take a stab at it. I think, and I'll link it to the question you asked me with respect to ESRD bundle. I think that one of the things in any bundle system that we do is underestimate the time and the coordination that's needed from physicians to interact in that bundle. And everyone shakes their head and they get that and they understand. And I think that when you are discussing payment reform and policies that are needed to be put in place in the continuity of those services, I think we oftentimes don't realize the importance of ensuring that patients as well engage and should be invited to engage at all levels as well. I consider sort of a toolbox of sort if you're patient organizations, and you have to realize that some organizations are geared to speak as NCCS specifically to quality of life and living beyond and living with cancer. You have some organizations that may be very data driven and some that are hybrid that have the ability to do all. So how do you as the patient groups ensure that we have a seat at the table for the patient voice? Earlier, Dr. McClellan spoke about the Part D rule and the attempt by the agency, the proposed rule, to remove some of the 6 protected classes, and the power of bringing all the organizations together to have one voice, and how he believes that that may be enough to move the agency. And I think that that's a great lesson with respect to the power that's in the voice of the patient, those experiences, how they interact within the systems. The fact that the decisions should, we do have to think about reform in the context of quality, cost, but you can think of the sort of hub or the spokes as all those other issues, and the patient honestly needs to be in the middle. And if we fail to do that, then I think we're going to miss.
So in looking at patient advocacy, all of us are patient advocates, I hope. In the role that I've described in me asking patients these questions, I'm functioning as a nurse navigator. I have other nurse navigators in our breast center as well. All of them are also breast cancer survivors. And rather than doing just the traditional nurse navigator role of identifying barriers that are going to result in this patient not getting the treatment that they need to have, so they don't have transportation or they don't have a prescription card, so they're not going to be able to afford their medications, et cetera. I'm saying we're taking this to a totally different level. And I want to make sure that you are the person that knows the most about this patient, to make sure that when that patient is not able, for whatever reason, to speak up for themselves, just because they're overwhelmed, that you serve as the patient voice. So the information from this 35-year-old, I know the night before that patient arrives to our breast center, and I present her case to the surgeon who's going to be seeing her. When the surgeon goes in and is going through the medical part, when he's doing the clinical breast exam, oh, I understand you're studying to be a concert pianist. And that's when that discussion starts to unfold, so that it doesn't take up more time for the physician. I'm trying to make that as efficiently as we can by having someone else gather that information, obviously the doctor to acknowledge it and to factor it into the treatment planning. I also believe that we should stop telling patients to accept their new normal or adjust to it. Do I look like the type of person that would have said that was okay for me my 3 times with cancer? Right from the start, I say, we're going to help you create your new normal. Tell me the things that you like in your life right now, which is obviously 2 said I don't want my husband anymore. And let's work on this during your treatment as to how are you going to look and feel when you're done. We allow patients to become deconditioned. We tell them, you're going to have fatigue. Accept it. Yet we've done research that shows if we have them exercise regularly, we could diminish or prevent fatigue. Why aren't we doing that? And I thought, this is silly. We do the research and then we don't apply it. So it's let's head things off at the pass so that you're not dealing with chronic fatigue when you get done. Let's get you into cancer rehab. Let's get you core strengthening before you have a deep flap reconstruction done, so that we maintain you or possibly even make you better from the perspective of your physical abilities. And as treatment, acute treatment is ending, the patient still needs a navigator as they enter a new world and looking at that world very differently. They're in touch with their mortality. This is a life-altering experience. I don't care what kind of cancer that the individual has had. We need to make sure that they're adhering to their surveillance and other screenings, because now they're at higher risk for other kinds of cancers as well as recurrence of what they've got. For a very large majority of breast cancer survivors, we're going to have them on hormonal therapy. And what does the physician say? Congratulations, you finished your treatment. I say, don't you dare say that. They aren't done their treatment. You're going to be giving them hormone therapy for 5 years, maybe 10 years. That could be the most important thing they get. Skip the other stuff we've already done. That may be the most important. And you say, come back in 6 months. She just finished radiation, seeing somebody every day. She gets out to her car. She thinks she's got toe cancer. She calls me. I've come out to the car. They said they aren't going to see me for 6 months. My toe is killing me. You know, it's my right toe. Cancer is in my right breast. I've been exercising. The cancer is shaking down. I already have distant recurrence. I don't say, no, I don't think you do. But it's that anxiety and fear. And what will they ask for? They go to the PCP because they know the oncologist isn't going to do it. I'd like to have a staging workup done again. I want to make sure I don't have any cancer in me. Now, PCP might order it. For risk management purposes, he might order it. But if a navigator is educating that patient, staying in touch with that patient into their survivorship care for several months, again, we can head some of those things off at the pass. We can make sure they're taking their medication, and if they aren't, why? Can't afford it. My libido went away. My husband said, go get it back. So I stopped taking this pill. How important is a pill? It can't be as important as my IV chemotherapy. All that education that has to happen, because we're trying to help that patient live a good and healthy life without giving her all the tools and resources that she needs.
Can I ask you, Mike, do you mind if I put you on the hot seat? As you roll out programs that I think of the contract that you have with Texas Oncology, is the patient voice involved in the construction of that product or that thing? And do you insist on satisfaction scores or something that comes back? How do y'all judge that?
So I actually have 3 answers for that. The first is, yes, we are requiring patient satisfaction as one of the core reductionist principles of quality metrics in these, but they are in fact not, you know, they're aggregate reporting, so there's some limitation there. The second thing is that as part of the virtual navigator program that I described to you, patient-related issues, patient-reported outcomes are a very, very prominent component of that dialogue. So we will get individual level input, and then I'm working on something else, but I'm not at liberty to discuss it. But I do believe that dialogue is critical, and I'm trying to actually develop a methodology for engaging patients, or at least patient representatives, because you can't reach everybody.
Brian Rosen with Leukemia and Lymphoma Society. So I think there might be an opportunity, and I'm glad Michael raised the point, and Shelley asked the question as well. You know, you probably will have legislation, physician payment reform, and there's a lot of people in this room, a lot of stakeholders, patient and provider advocates who can influence CMS and the regulatory aspect of this, because a lot of it is being punted over to CMS for implementation, and especially on the quality measures. So, I mean, I think there's an opportunity for the folks in this room to come together and, again, ask Congress to ask CMS to pull all these stakeholders and determine what the quality measures are, and include patient satisfaction, and include patient-reported outcomes, and include the patient's voice and perception of what is success, both qualitatively and quantitatively. So I think it's an action item coming out of this this meeting. Great discussion, by the way, and I think that it's an opportunity, and we shouldn't miss it. So, you know, it's probably 2 months away from now, maybe a month or so, but I think that it's an opportunity to influence the regulatory component, which is something that we have to get used to. That's probably where our greatest voice can be heard.
Thank you. I'm Peggy Eastman with Oncology Times newspaper, and I'd like to ask about the standardization of process that has been discussed, and whether that could be used as a way of making it a little easier to have that very difficult conversation with metastatic patients. You know, it's really probably time to stop treatment, active treatment now, because Lillian, as you said, neither the oncologist nor the patient really wants to have that conversation. And we know from studies that some patients are going on to have chemotherapy way beyond the point where it is effective, and what it is doing is just causing them some horrendous side effects in some cases.
First I would say yes to what you said. Process standardization is one way to ensure that those conversations would hold, but I'd back all the way up and say when a patient is defined with metastatic disease, there ought to be a clear iteration in the clinical record of a discussion that defines the goals of care. And in our practice, I come back, yes, it's always about me. You've got to understand that. Any nurse understands that it's always about the doc. But I'm sorry. But I think in our practice, clearly that has been a challenge, a big challenge, to just get docs to document because and to have that conversation that, look, we're fixing to begin on a journey. And certainly it's cognizant, it would be better if there'd be more storytelling around that journey. But just the fact that it's a journey, that ultimately this disease is going to take your life. And define that we may go through several steps. And in fact, it could be potentially a long journey of years, but ultimately it will come to its end. Reinforcing that conversation during the journey then makes it extraordinarily easy. And that's when the patient's voice often does come back to me and say, we're not doing anything else, or I have something else I want to do this week. So I sort of roll it back. More critical even than that final discussion is coming back on how we set our goals and communicate them early in the course.
I think communication is one of the biggest challenges, how to teach in medical school that communication skill and having that kind of discussion so that it isn't avoided or I'll push it off till the next visit. We do know from research that by being honest with a patient with advanced disease who will lose their life to their cancer, by explaining to them what we anticipate happening going down this road, does not take away hope. We've always believed until research was done, I don't want to discuss it, but I don't want to take away their hope. It does not take away their hope. They may begin looking at transitioning to different hopes and ones that are more realistic and achievable, and then looking at alternative ways to fulfill hopes, such as the card example that I gave you. But I don't think that there's enough training that does fill this incredibly important niche so that the patient and the physician are on the same page as to why are we doing this treatment. Even the word respond, there's 5 research studies looking at very solid tumors that when the oncologist says to a patient, I am hoping that your tumor will respond to this next treatment for breast, prostate, colorectal, and lung cancer, between 31 and 80% of patients thought that meant cure. So back to communication, that obviously we think that our patients know what we're talking about when we're using words that are not in their vocabulary from a medical perspective. So if a patient that, great, I'll take it on, I'll take all of the side effects with it, I'll take the expense with it, only to find out that it wasn't what they thought it was going to be. And one of the elements of experiencing a good death, or to have a good death, you need to know your purpose of having lived in this world. You need to leave a legacy, which does not mean money. So with my dad, it was being the patriarch for farmers on the Eastern Shore of Maryland. And you also need to not leave debt associated with your cancer treatment for your family to pay. and you need to have your pain in well control. Those are all things that you have to have in order to have a good death. And I think the one that's financially driven is one that is one of the most alarming to patients. Patients may be taking treatment not because they want it. Their wife wants them to have it. Their daughter wants them to have it. And they give in to that. And I always say this is his life, not your life, her life, not his life, to make those kind of decisions.
So Dr. Cox, I mean, the standardization of process doesn't help with, that ability to communicate, like Lily talked about. I mean, what can we do to help help physicians have those difficult conversations?
We were talking about this earlier to break. It's a learned skill, and I don't think we pay as much attention to it as we need to. I worry. I guess this is one of those things that happens when you get old, is you begin looking at the power of language, as you just outlined about the word response. But as I step back a little bit and have a little more time to reflect and listen to what's going on in the clinic, it is amazing to me how we communicate, how my colleagues communicate. I'm not just dishing them. I think it's a pretty common thing that oncologists, the physicians, we tend to be focused on the next widget and what the next thing we're going to do in our algorithm, and we're not sometimes ideally communicating or taking any of these things into account. It is a skill. There are programs that sort of can teach old dogs new tricks. I think as more emphasis comes on this, physicians can be prompted to get involved in that. I think it's also imperative that the voice of patient organizations stand up and demand a better, clearer conversation about this. And I also work heavily with ASCO. It's something that I think we underplay at our meetings, that we could do a better job of figuring out programmatic ways to teach folks. But it is a skill, and I think it's a skill we have ignored a bit.
I think if we look statistically at those patients that died in an ICU, those patients that were getting chemotherapy in the last month of their life, that probably would guide us as to which physicians are in the most need of help with learning how to have that kind of discussion. Mm-hmm. And then there'll be some that you can see they enrolled them in hospice and they survived for 4 to 5 months after being enrolled in hospice. That's as it should be. That's what I want to see. Here's some questions.
Do we have time for one more question? Yep. Okay. One more, John.
Just a comment that really kind of reinforces the things that Lillian said and John said. Let me just mention, or I'll admit something, that physicians really, really need help. We need help in a way of having reliable data presented to us so that we can react. Lillian, you mentioned about doing the initial interview with patients and finding out what's important. That's process standardization. Your physician was armed with the appropriate information so that he could go in and make that part of his decision making and part of his discussion. I can tell you that, and John, you're probably experiencing it, that with standardization comes efficiency for physicians. And when physicians have efficiency, the conversations change. I can tell you, prior to process standardization, if I saw 25 patients in a day, I took great care of the first 8. I took okay care of the next 8. God only knows what I did or what I missed for the last 8. Really, and I thought I was doing a great job. Process standardization really is a big benefit for physician decision making and for driving consistency of care. It's especially in a complex arena like oncology.
Thank you. Well, Dr. Sharstein is here, so I want to conclude this panel and thank you all very much for participating.
Thank you.
So we'll move along to the next speaker. I want to take a moment to introduce Dr. Josh Sharstein. Thank him for coming here today to share his thoughts with us. Josh has distinguished himself not only for the quality of his ideas and his dedication to public health, but the manner in which he has pursued these concepts. Josh is a practicing pediatrician and Secretary of Health for the state of Maryland. He previously worked as Deputy Commissioner of the FDA and as a senior staff member on Capitol Hill, where he worked on major public health legislation. In an environment where there's a lot at stake politically and where differences between people's ideas can sometimes be sharp and where the debate can occasionally get intense, Josh is a happy warrior. For his ideas, he sought ways to forge the kinds of partnerships that lead to enduring change. It's a working style, I think, that's born of what has been in his public life, his singular focus on ideas, on the power of ideas to advance the interests of patients and consumers. We are very pleased to have him here today to join us to talk about one of those ideas, a very innovative set of reforms he has advanced in the state of Maryland that could well become a national model for delivery system change. And with that, I'd like to turn it over to you, Josh. Thanks a lot.
Thank you very much for having me, and thanks, Scott, for the introduction. I have a great respect for Scott, even though we don't agree on absolutely everything out there. And I think this is a terrific event. It's great that you all are here, and the discussion that I just heard was fantastic. Glad to see someone from Hopkins there. But I do want to be clear that I didn't come here just because I accept everything not related to the IT challenges of implementing health reform. I should say that I actually am very interested in this topic, and this is a really, really important moment. Let me just, I'm going to talk generally from a public health perspective and payment reform, and I'm going to zoom in and back out on cancer. So, you know, I'm a pediatrician. I'm also a public health physician, and if you take a look at the big picture of cancer care in the United States, I think it'd be fair to say that it's pretty expensive and getting much more expensive. Our outcomes overall are not terrific. If you look at international comparisons, we're kind of in the middle by a lot of comparisons. There's no question that there are many patients that get absolutely terrific care, and there's also no question that there are a lot of patients who do not, and that there are tremendous disparities in rates of cancer and the approach to treatment. There are enormous gaps in prevention for cancer around the country, and that leads to unnecessary cases of cancer from my perspective, and we have an aging population that's going to increase the number of cancer patients. So if you think about the patient as the population, it is not, you know, we have a overall expensive system that doesn't provide, I think, the results and the consistency that we would want. And then if you zoom in on the individual, I think you've just heard a lot about how the fact that cancer care is not optimal for a lot of patients. It can be very difficult, painful. There can be multiple readmissions. Many patients run out of treatment options, and there are inadequate treatment options for a lot of cancer right now. And then just in general, many patients suffer, like everyone in the healthcare system, from just the complexity and the bills that come in, and it's, you know, when you least want it. Right before my wife had our second child, which is partly why she felt no sympathy for me, I had a kidney stone. And they thought I had appendicitis, and so they billed me for appendicitis, but on the way to the OR, I basically, you know, hopped off the thing and said, it must have been a kidney stone. I'm totally fine. There's no way it could still be appendicitis. And sure enough, it was. It took me a year to get that bill removed, you know, going back and forth. And I think at the time I was the city health commissioner. That didn't help very much. And I had to call and basically threaten to show them that I had no appendicitis scar before, no appendectomy scar before I got that cleared up. So we really have two problems, or that we have a system that is very expensive, but it lacks a lot of the breakthroughs that patients need. It lacks the prevention. It's sort of like a restaurant where the food tastes terrible in such small portions. You know, we need two things improved here. And what makes this especially frustrating when it comes to cancer is that there's so much scientific progress being made. There's so much interest in personalized medicine. From time to time, there are these incredible breakthroughs. There's the sense that there's just so much that could happen on the treatment side, and yet we're held back. So many patients are frustrated, and we're spending so much money for not great outcomes. So the premise of payment reform is that cost and outcome can be improved together, that these are not at odds, that it's not that the problem is we're spending too little, it's that the incentives are wrongly set, that you can reshape payment and actually get better outcomes. And I have learned about this, particularly in this job as secretary, where we do a lot of engagement in Maryland with the healthcare system. And I'll tell you that one story about pretty early on, I was invited to meet with the Baltimore Ecumenical Council. And I had never met with this group, even though I had been previously the city health commissioner. And they invited me to come, and I was late, so I was feeling guilty to begin with. And I walked in, and there were 12 priests or ministers, all in their severe clerical garb, sitting around a table, looking at me as I walked in. So I felt bad, and they wanted me to talk about the Affordable Care Act, and I was talking my best, and I wasn't getting very much reaction from them at all. And finally, one of the ministers said, well, why does healthcare cost so much, Dr. Sharstein? And I started in a little bit about tobacco use and obesity, and I said, but you know, tobacco use is going down, cardiovascular risk factors overall are going down, and yet costs keep going up, and it has a lot to do with the way we pay for healthcare. You know, if we keep paying by the admission, by the procedure, you know we're going to get a lot more admissions and procedures. It doesn't necessarily mean that people are going to be healthier, and we just keep seeing the bill going up. And usually when I say that, people are nodding, and these guys were like completely stony-faced, and I felt bad for coming in late, and so I said, you know, I was trying to make some connection with them. I said, you know, it'd be as if each of you were paid by the prayer. So then there was this like excruciating silence, you know. My career flashed before my eyes. And there was one guy sitting across the table from me who, in my recollection, was wearing a cape. He might not have actually been wearing a cape. But in my recollection, kind of a pointy nose, leaned across the table, put his hand on my hand, bowed his head slightly, and said, "Let us pray." So that's basically the concept of payment reform right there. And when I was the city health commissioner, I learned about this. One of the fun parts about being the city health commissioner is you get to interact a lot with some of the other leaders in city government, and so it's an emergency and you're in the bunker, and I'm in the bunker with the police chief and the fire chief, and we're talking, and the fire chief pulls me aside and says, you know, Judge, we're having trouble with ambulance response times because there are people who keep calling the ambulances. I mean, again and again and again and again. Is there anything you can do to help with that? And I said, well, can you give me a list of them? He said, sure. So we did a pilot. We reached out to the top 10 users of ambulances in the city of Baltimore. And number one was a woman who called them 5 times a week. She was 92 or 93 years old. She never got transported to the hospital. She thought the EMTs were cute. They came by, they chatted with her. They went, so we found her a sufficiently cute replacement home visitor, and she was totally fine. Number 2 was a woman whose husband thought that when you gave insulin, you were supposed to go unconscious and call 911. He was, if you know the history of treatment for depression, he was treating her depression. It used to be before the advent of antidepressants, and I met psychiatrists in the Navy say who they would line up the depressed patients and give them insulin until they seized, and then give them dextrose until they came back. You know, it was sort of like an early ECT. But that's basically what was happening, and she was going unconscious from the insulin, and they got her on the right insulin dose, evaporated her ER visits, and we published a paper. It was cost saving in the ambulance costs alone. Forget about the ER costs, the hospital costs, the intervention, and you know, we showed it to the emergency room doctors of the city of Baltimore, and they got down on their hands and knees and thanked us. They were so excited. They helped us write it up. And all of us knew there wasn't a chance in the world that we could really get the hospitals to invest in that, because we were keeping patients from the ER that they really, needed the revenue for. And, and where you see that is you see, like, on the billboards on the side of the highway, like only 2 minutes in our ER, And so, I mean, if you take a step back, like, how does that healthcare system make sense? Why are we spending so much for care that is it's not in the interest of the patient? It's not in society's interest to be spending all this money. That's the basic premise of payment reform. So let me talk a bit about Maryland. I'm going to zoom back in on cancer in a minute. So in Maryland, we've been very interested in trying to align payment for value more than volume, if you've heard that, get away from the fee-for-service approach. And we've had some unique opportunities because Maryland is the only state that sets hospital payment. We have an independent commission that sets the rates. It's been going for 3 or 4 decades now. And it generally was fee-for-service. It would set the rates. And in Maryland, Medicare pays Maryland rates. It doesn't pay Medicare rates. We're the only state that Medicare pays Maryland rates. So a few years ago, they started doing some innovative things. For rural hospitals, the system made a deal to provide a global budget. And let me just explain how everything I say here is going to be simplified, not because I'm trying to simplify it, but because this is how I understand it. But you do a global budget, and when I say sets the rates, it's for all payers. It's for Medicare, it's for Medicaid, it's for Care First, it's for Aetna, it's for everybody. They all pay the same rates, essentially. And so if you're the hospital CEO, if you have a global budget, it's essentially, if I say your global budget is $100, that means that if you're going to have 10 admissions, you're going to get paid $10 per admission. If you have 20 admissions, you're going to get paid $5 per admission. If you have 5 admissions, you're going to get paid $20 per admission. So it totally changes the fee-for-service approach. And then other hospitals, including Johns Hopkins, signed up for a different kind of payment incentive around readmissions. This is very different from the federal readmission penalty. The federal readmission penalty is like you're under this line, boom, you get hit. In Maryland, what happened is we basically said, okay, last year you had $100 of readmissions. We're going to give you $100. Now you're on the hook for all the readmissions. So what does that do? It makes the hospital, it totally changes the hospital's thinking. I've had some of the CEOs retire. One of them said to me, Josh, the whole time I've been in the hospital business, I walk through the cafeteria on the way to my office and I know how we're doing. It's just how busy the hospital is. But now I don't know if they're readmissions, I don't know what's going on. It's just a nightmare to figure out how we're doing. So I think it's better to leave this to the next generation. I field a lot of calls about the exchange, and I'm always, giving reporters ideas of other things to write about. So for a while, I was saying, if you really want to write a great story, drive out to Cumberland, Maryland, where Western Maryland medical system, it is like the anti-gravity zone for healthcare. You go out there, they're on a global budget. The hospital is quiet. It is 60% full when I was out there. In the ER, they have teams that go around and meet with each patient to make sure they're plugged in. They don't have a billboard on the highway, only 1 minute in our ER. They try to connect people up to primary care. They partner with the public health department, which is across the walking bridge. They actually have a really innovative end-of-life program. And when they send patients to long-term care facilities, they send nurses out twice to make sure the transition is right. The CEO, who's been the CEO through the transition, said it's a culture shift. We practically have signs up, we don't want to see you again here, which is unusual for hospitals. And finally, I got, the New York Times drove down to Cumberland, wrote a terrific story about what's going on there. And it was partly out of that. As our arrangement with Medicare really started to peter out, and I could get into the details, we really were at a crossroads. Are we going to maintain an all-payer system? And so we negotiated for over a year with CMS and basically said we're going to go all in on these types of pilots. There are other ways, generally speaking, where we're no longer paying on the basis of fee-for-service, where hospitals have a much greater incentive to see better health in their community and fewer admissions, and that they're not at risk financially for doing it. And we've pledged to do that over 5 years. We've guaranteed savings to Medicare. We've committed to very aggressive quality targets as part of that. Let me just also say that as another, just a very brief other example, there's another hospital with this global budget that took over the school health program. Now, it's the only part of our state where the hospital is running the school health program, and I asked the CEO why, and he said, well, we figured we could run the school health program at break even, but save money on the asthma ER visits, which are really killing us. You know, I mean, so that's a win-win all the way around. I've had other of the CEOs say, Josh, we need help because we realize so many of our readmissions and admissions are coming from the behavioral health community. You know, I mean, the behavioral health needs, huge percentage. What do we do? I mean, and to have hospital CEOs trying to figure out how to improve the mental health, substance abuse of their communities, hugely exciting. So let's talk about cancer. I think it'd be fair to say there are major payment problems in cancer along these lines. Some of the same fee-for-service incentives that I'm talking about generally apply in cancer. I would venture to say that the way chemotherapy is reimbursed does not make any sense from my perspective, from a rational basis. I read one health affairs office that called it the buy-and-bill system. There are enormous variations in costs and outcomes, and I think that there are frankly incentives not to have the kind of candid discussions that we were hearing about being really necessary for patients. I certainly remember my wife when she was on the wards, and her worst rotation was oncology because she had a doctor who just did everything all the time, and patients had no idea that they were dying, and it was left to the exhausted interns to tell them or not. And it was just one of the hardest things that she experienced. There really isn't, I think, globally at least, payment for how well the patient does, how well the patient, even how well the patient does. Even if you're in a cure situation, you know, you're not necessarily reimbursing on the basis of outcomes, or honoring the patient's wishes or patient satisfaction. It's very much still based on fee-for-service with its very bizarre incentives around chemotherapy. Not to mention the fact that there aren't, in many ways, tremendous incentives for screening or prevention. So let me mention three aspects of payment reform, and then maybe I'll stop for cancer and then see if there are any questions to discuss. First, generally payment reform, then cancer specifically. And third, I want to challenge you to think a bit about payment reform and innovation in therapeutics for cancer. So first, generally, I think that I would make the case that this general payment reform issue is important to the cancer community. What we're doing in Maryland generally is why. As you think about all the things that really need to happen for community health to improve, you're talking about cancer prevention, and you're talking about better ties to the healthcare system anyway. So if there is an effort, you know, what's one thing a community can do to reduce its ER visits for heart attacks right away? Reduce smoking. There's probably 5 really good studies that indoor air policies reduce smoking and can be seen right away in ERs. You reduce smoking, you're going to reduce cancer. If you are working on dietary initiatives or other general public health initiatives, the whole switch in payment reform to thinking about prevention and health is good for cancer in the long run. So I would be remiss as a public health physician if I didn't make that general point. I would also say that the more there's generally focus on these things, you will see much more attention to quality measures that relate to screening for cancer as well. Second, I think that there are reasons to believe that you can do payment reform, particularly for cancer, things like bundle payments that can produce better outcomes. There are several examples out there you may have touched on probably earlier before I came here. There's a good case study from Harvard Business School about breast cancer care in Taiwan. I met the doctor when I was out there who led that. United has done some interesting work taking the financial incentive about chemotherapy out, and for certain cancers, trying to standardize care so that people really get the recommended treatment. Hopkins in Maryland with our payment system, there's certain bundles that actually are paid. including around bone marrow transplant. And I was speaking to Dr. Nelson, who runs the Kimmel Cancer Center, and he said one of the best things that they've done recently is a bundle for bone marrow transplant. It allowed them to move a lot of that to an outpatient basis. He said the results have been terrific. The patients do better when they go home, and they've been able to keep the difference. And it probably never would have happened without the bundle being done. Obviously, there are, and there are experts who are much more knowledgeable than me about when it makes sense to zoom in on a particular condition and how you design the payment reform. And those details really do matter. You know, from what I understand, you need to have population you can define, good understanding about the treatments. You have to be able to allow for uniqueness in the patients and some flexibility. I think the idea that a patient should be part of that discussion as these things are structured is very important. But I do think there's tremendous potential when you think about what can be done once you've established those bundles to support patients. It really takes the financial pressure away, and so much more can be done. Speaking about the end-of-life issues, you know, at Western Maryland, I met a doctor who said that, you know, he's really been interested in setting up a model end of life, but it's been really hard in every hospital he's worked in because the financial incentives have always been in the other direction. And just to have some space to be able to think about what the best model is, you know, is really in the interest of patients and their autonomy. So, and now he's able to move forward with that. I think that as bundles get set up in cancer, I think it works in both directions. I think it means that on the cure side, that there's more ability to have higher quality care and more people being cured, as well as more attention to some of the other needs that patients have. Let me just, let me see how I'm doing for time. Let me just conclude by talking about innovation, because I think it is an important part of any discussion of cancer. Scott and I may have come from, you know, different political positions, but I think both of us are very much interested in seeing the scientific frontiers advance and patients have access to better treatments. And it's certainly maybe the elephant in the room is if you switch from a fee-for-service payment, does that mean that we're taking away the incentive for novel therapeutics? Does it undermine the ability of the biotech industry to move forward? And we certainly don't want to do either of those things. Interestingly, I was in a mixed company, and by that I mean there were some Republicans in the room. And somebody was actually someone who I think was comes from that persuasion, told me that he was very interested, as we were talking about what we're doing in Maryland about this, because he was working with a company that makes a diagnostic, and he said that the diagnostic really helps target the chemotherapy and can really show where it's going to work. But the doctors weren't interested at all because they get paid entirely on the basis of whether they use the chemotherapy or not. And that to do a diagnostic that tells you it's not going to work was not in their interest. And he was very interested. He was asking me all sorts of questions about could we get payment more generally that would actually drive interest in products that would improve value and improve outcomes. That when you're only paying for the quantity of chemotherapy, then you're not going to get the market, the innovation that you actually want. And, you know, I've heard, you know, different proposals for major investments in medical research, and I am all for major investments in medical research. I can't, you know, unfortunately print money to make those, but I can look at the healthcare system and say we're spending $3 to $4 trillion a year. Could we take any of that and orient that more towards a market for more innovative products that produce benefits for patients? And I think that one of the questions that Dr. Nelson at Hopkins asked me, because I saw him a couple days ago and I asked him about this question, he said that, you know, his view is that the reimbursement system is so focused on the immediate and doesn't take the long-term view of the lifetime costs that it's very hard for people to think of a model of different types of therapies that produce better outcomes. And I don't have the right answer to this question, but I do think it's the right question. That the incentives in the healthcare system, they haven't served public health well. I think to a certain extent they have not served drug development well. And as we have this opportunity to change payment, it's more than, it helps patients in multiple directions, but we have to be cognizant about the incentives that it's establishing for for product development and the kinds of innovations in care that don't just lower costs but actually improve outcomes. And given the incredible amounts of money that we spend for treatment, that should be, on everybody's mind. And I think, if there are, and I think you can see the beginning of that in some of the payment reform efforts in cancer, but I think that it is something that should be kept in mind and is something that I think offers a lot of potential if it's done well. So I hope I've given you enough to think about broad as well as on cancer, and I'm happy to answer any questions you might have. Thank you. I know somebody's got a question here.
I'm very interested in the Maryland all-payer model because if I could take 5 seconds to give background, I'm Canadian, and it would be bizarre in Canada for the federal government to think it could set physician fee schedules or how to pay hospitals. It's all done by the provincial health plans. So is this if you were in the future to find yourself at CMS or back on the professional staff, would you encourage other states or the federal government to encourage other states to do this model, or is this something that is idiosyncratically unique to Maryland for some reason that you can explain to us? Thank you.
Well, the idiosyncrasy in Maryland is that there's a provision of the Social Security Act that has Medicare paying Maryland rates. So that's probably why our system, one of the reasons at least, why our system has been so sustainable. I think Vermont is actually really looking seriously at a model like this. I don't think it's likely to, in this form, to be adopted by other states. But I think that there are going to be some lessons. One of the things that I didn't talk about so much but is very important to CMS and to us is that by aligning all payers, you can really get clinical transformation. It's very hard if one payer is doing one thing and everybody else is fee-for-service to get clinical transformation. You don't get the cultural shift of we hope you don't come back to the hospital unless you're doing that across all payers. And what we're going to try to do is we are going to be innovating in terms of bundles and other things, and having the ability to do it on an all-payer basis may provide some insight on whether these things actually work. That may be a better insight than you can get when it's just with 10 or 20% of the patients for a particular. So I think we hope to provide some lessons to other places, even if they're not going to go all the way into payment regulation, price setting.
Hi, I'm Michael Oj from Aetna. So here's my question. The all-payer fee schedule setting, is that just for the hospital fee schedule? Is that for physician fee schedule as well?
Just the hospitals.
So there's ample evidence that there's a differential, site of service differential. We were reminded yet again yesterday by the high mark shot against the bow of UPMC. So my understanding in Maryland is that the hospitals got around it initially by churning. So they had more clicks, and now you've set the budget, so that was your remedy. Well, so how does this work for physicians?
So our new arrangement with CMS includes both inpatient and outpatient hospital expenditures. So there's no opportunity to blow up the bubble on the outpatient side. That was very important to us and to the state and to CMS as well. We also are very interested in having a collaboration between hospitals and physicians to accomplish these goals, and that occurs at different levels. One potential is through gain sharing, similar to what Medicare permits under certain circumstances. One potential is between more explicit relationships between hospitals and groups of primary care doctors that are operating medical homes to share in savings as it happens. And then there's also the potential for, we're working on right now with the General Assembly to dedicate some funds for partnerships between hospitals, physicians, long-term care, and others in the community, so that we're really trying to pull together a system of care that really where everybody's interests are aligned as it gets better. So, I mean, I think that the previous system had strengths and weaknesses. I think that we had very high volumes, in part because I think of the fact that the prices were kept down by our previous arrangement with CMS. We are solving that problem by by going to the overall budget. But to be successful, there's going to have to be an alignment with physicians. And I think that's going to be one of the most interesting things to watch in Maryland. And I think so far, we have a bunch of work groups that are developing things. CMS is ready to get applications for us about gain sharing and other items. And we're going to also pursue a few extra funds to seed partnerships. I'll tell you that, from the public health side, you've got a huge cultural gap between medicine and public health, and the idea that people can work together and really be vested in that partnership is really a new thing, and a huge amount of our energy is going into that. But it's also a bit similar with the physicians in the hospitals, and I think, my guess is there'll be some variation, and our goal is going to be to try to, lift the boat as people are successful in different parts of the state to do that. I don't know if that's a good enough answer for you, but happy to talk more. Anything else? Okay, well, thank you very much for having me. I think it's been a terrific panel today, and anything that we're doing on cancer, we'll send down here, and please let me know, anybody, if you're interested in learning more about what we're up to in Maryland or have any ideas or comments. Thanks so much.
I just want to thank everyone for coming today, and thank the National Coalition for Cancer Survivorship for all their help in planning today's conference, and all the folks at AEI, the conference staff, and the many panelists and clinicians who traveled very long distances to be with us. Thanks a lot for coming.